Well, good afternoon, or depending on your time zone, good morning, and welcome to this Duke-Margolis event on your treatment and your community, advancing evidence and policy for medical products that impact others. And we're specifically focusing about infectious diseases in this event. I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy, and I'm also an independent director on the boards of Alignment Healthcare, Cigna, and Johnson & Johnson, and receive fees for serving as advisor for Arsenal Capital, Blackstone Life Sciences, and MITRE. Turning to the event, this event comes at an important time with outbreaks of infectious diseases like measles, norovirus, influenza, tuberculosis, and whooping cough around the United States. But it also comes at an important time from the standpoint of innovative biomedical products that can potentially affect the spread, as well as benefiting the individuals who choose to use these products. The products consist of vaccines that can not only help individuals reduce their own infectious disease risks, but can also, in many cases, reduce the risk of transmission to others who don't use the vaccines, as well as therapeutics and diagnostics like PCR tests and genomic tests and now over-the-counter tests, as well as diagnostic tests that can be pooled for screening. These products, too, can help their users stay healthier, but they can also help reduce spread and benefit others in the community. And all this also comes at a time when there are better data and methods than ever to use information from real-world settings, community settings, to understand these impacts that go beyond the benefits and risks to individuals, the ones that are typically the focus of clinical trials that bring an infectious disease product to market, to consider and incorporate in our policies the impacts on others. The capacity to evaluate these indirect benefits is improving. This is building on research around population health impacts of vaccines, but increasingly around real-world impacts and assessments of the use of therapeutics and diagnostics for containing infectious diseases in communities as well. Now, to receive marketing approval, coverage, and payment, a medical product like these typically has to go through established processes for using evidence to demonstrate that the direct health benefits of the product to the individual that's using it outweigh the risks. The Food and Drug Administration has well-developed standards to weigh the benefits and risks, assess the evidence on product use for this purpose. The Center for Medicare and Medicaid Services has established methods to judge whether products should be covered based on being medically reasonable and necessary, appropriate for addressing a disease risk, and now including evidence-based preventive services. And there are increasingly available, along with this, real-world systems being used to track the safety and effectiveness of these products as they are used by individuals. For example, the Biological Effectiveness and Safety Initiative, or BEST, product monitoring system used by FDA's biologics centers, tracks adverse events and also helps assess real-world benefits to users of these products across secure, anonymized data for over 100 million Americans. Based on this evidence and coverage, many Americans voluntarily choose to use these products for their direct benefits to their own health, the reduced risk of infection, the reduction in symptoms and serious consequences. But as we've talked about, when people choose to use these products to improve their own outcomes from infectious disease risks, they also can provide indirect benefits to Americans who do not choose to use or don't have access to the products, for whom the products are not appropriate. For example, vaccines in people with weakened immune systems. For infectious diseases, these indirect benefits for a community add to the direct health benefits of the products to impact overall population health. For example, through a greater impact on reducing transmission that better protects higher risk contacts of an individual in a community. Yet these indirect benefits have been increasingly noted, but we don't yet have clear public policies or well-developed frameworks for assessing, valuing, and supporting the development and use of biomedical innovations for infectious diseases that have such population impacts above and beyond their benefits and risks for individual health. The absence of this clear policy guidance in the light of the occurrence of more biomedical innovation that can potentially help reduce transmission has significant public health implications, especially in settings like the US and many other countries where there's limited support for vaccine or treatment mandates or other restrictions on individual choices to contain infectious diseases and improve the health of the population. Current regulatory coverage and payment policies can encourage the use of vaccines, therapeutics, and diagnostics that are safe and effective, but they may not fully reflect these indirect benefits that arise with widespread use of products, especially products that are developed and have supporting evidence produced on the benefits to others. To address this, in collaboration with a diverse set of experts and stakeholders, Duke-Margolis has developed a more systematic framework for policies related to infectious diseases to account explicitly for the indirect benefits of medical products to advance population health, with the broader goal of reducing the burden of infectious diseases through better evidence and more informed individual choices. We'll first present this framework. Its goal is to foster informed individual and clinical decisions about the use of current products to limit the burden of infectious disease, and, as I mentioned, to support the development of next generation products that target reduction in transmission as well as the individual benefits. We'll then have some further discussions of two key complementary dimensions of this policy framework: improvement to generating evidence on indirect benefits, and steps that federal agencies like the Food and Drug Administration and the Center for Medicare and Medicaid Services can take to integrate indirect benefits into policymaking processes. Throughout the sessions this afternoon, we'll touch on a range of examples relevant to the infectious disease space, playing into the context right now of current disease outbreaks like measles. And we'll use respiratory viruses, both today and in the papers that we've released in conjunction with this event, as case examples, given the high burden of respiratory virus infections in our communities. For example, seasonal influenza outbreaks that have been occurring in just recent weeks. Importantly, these discussions will focus on opportunities for forward-looking, collaborative strategies that connect the priorities and needs of patients, healthcare providers and health systems, regulators, product manufacturers, and other stakeholders for the benefits of population health. And finally, I'd like to acknowledge our support, which we very much appreciate, from the Gates Foundation for this work. And you can go on to the next slide. It's our statement of independence. Just a few, as part of a few logistical reminders here, the Margolis Institute is a part of Duke University, and as such, we follow the tradition of academic independence, really independence of all of our participants on behalf of producing effective work that takes account of diverse perspectives. Neither Duke nor the Margolis Institute take partisan or advocacy positions, but all of the participants in our efforts are free to speak their minds, express their opinions on the important and timely issues that we're discussing. On the next slide, a few reminders to help make the most of this important and timely virtual discussion. The meeting materials are available on our website. We'll be putting links into the chat as we go through the sessions today. For all of you who are attending, first, thanks again for being here. If you would like to ask a question during the presentation and open discussion parts of the meeting, please put it in the Zoom Q&A box. We may not be able to get to all of these, but we'll try to cover as many as possible. And if you have any technology issues and are able to, please put your issue in the Q&A box or email us at margolisevents@duke.edu. And for everyone, recording of this meeting will be available on the Duke-Margolis event website and our YouTube channel after the conclusion of the event. Again, thanks for joining us, and thanks in advance for all of your contributions to making today's discussions as interesting and productive as possible. Now, before we get started, I want to go over the agenda for today's workshop. We do have a lot to cover. We're going to begin with a session that highlights what we mean by direct and indirect benefits for infectious disease products. We'll try to use this to illustrate why indirect benefits matter and then describe some of the opportunities to improve population health by more systematically considering and factoring indirect benefits into regulatory and reimbursement policies. After this overview, which I'll present, we're going to move into a discussion about assessing indirect benefits and population health outcomes, how to incorporate them into strategies to inform policies and inform the decisions that individuals make about using products that can improve their own health and reduce the burden of infectious diseases in our communities. Should be an interesting discussion to tee up the rest of the afternoon. Then our second session will build and build out from one of our reports published ahead of this workshop that reviewed the current state of evidence generation on indirect benefits and described opportunities for developing further insights about these benefits for population health. Then we'll take a break, 15 minutes from our virtual time together, followed by our third session, which will consider actionable regulatory coverage and payment policy reforms that can leverage evidence on indirect benefits to inform individual decisions about products that can reduce infectious disease risks and their impact in communities. The session will build off another white paper published ahead of this workshop on policy steps that FDA and CMS can take to further clarify regulatory and reimbursement policies and pathways for recognition and incorporation of indirect benefits and their population health impacts. After these panel sessions, I'm very pleased that we're going to be joined by former FDA Commissioner and infectious disease policy expert Scott Gottlieb for a virtual fireside chat to pull together, reflect on some of today's themes and where we go from here in terms of reducing the burden of infectious disease threats. Throughout the sessions today, we'll be joined by a diverse group of excellent panelists to share their perspectives on advancing evidence and policies related to the individual and community benefits of medical products and coming biomedical innovation for infectious diseases. So with that, I'd like to shift to actually starting our first session on a policy framework for considering direct and indirect benefits. I'll provide an overview here, and then we'll move into a moderated discussion with two experts who have thought and done a tremendous amount of work in this space. So on the next slide, the development and the availability of medical products advances our ability to diagnose, prevent, and treat many infectious diseases, resulting in significant reductions in deaths, hospitalizations, and infections. Novel products, as we've just talked about, are generally approved for use and reimbursed based on evidence demonstrating their direct health benefits to the individuals who use them. Claims related to these individual benefits, which are regulated and approved or authorized by the Food and Drug Administration, are generally based on evidence provided by the manufacturer, just summarized on the product label, and the claims that the manufacturer is able to make, evidence-based claims about the products, which are in turn used in public education, communication, outreach. These often, as I said, focus on individual benefits, and within that, often focus on reducing the risk of severe infection and death, the health complications that are most consequential for individuals. But because infectious diseases can be transmitted to others, innovative products also have these important indirect benefit considerations for people around the individual who uses the product. So turning to these definitions of what we mean by direct, indirect, and overall benefits specifically, direct benefits, again, are the benefits to people who choose to use a vaccine or other product based on the evidence and what they know about the product's expected benefits and risks, and are, as a result of these actions, potentially less likely to get sick or experience severe disease or downstream complications. Indirect benefits are the benefits to others who may come into contact with product users as they go to school or work or otherwise interact in their community. These indirect benefits occur because the disease does not spread as much, leading to less harm of the disease in the community. In other words, an individual's decision to use a product impacts more than just that individual. It impacts the people that they work with, live with, spend time with. The overall benefits of a product, an infectious disease product in a community, are the sum of these direct benefits to the users and the indirect benefits. For example, influenza vaccination significantly reduces community level infection rates and hospitalization rates, such as reductions in, and also non health benefits like reductions in school and work absences, in part from their direct benefits, but also in part from these reductions in spread to others resulting from the vaccines. And what we want to do is be very specific and intentional about understanding, assessing, and acting on these two complementary types of impacts, individual direct and indirect community. So next slide. This figure taken from one of our papers shows that identifying and understanding indirect benefits requires studies and assessments that not only look at the impact of a product on an individual, but they consider the community context, the impact on others with whom the user interacts. Many of you are probably familiar with the indirect benefit of what's called herd immunity provided by many vaccines when they're used widely enough. If vaccine levels are above a threshold that depends on how transmissible the infection is and the effectiveness of the vaccine in reducing transmission, which is different from reducing, not exactly the same thing as reducing severity in an individual. Those who are unvaccinated also get protection from the disease. We're seeing this playing out right now with the measles outbreaks occurring in some states in the United States now. Infants are not vaccinated against measles until they're 12 months old. That's based on evidence of when vaccination is most effective as well as safe. The threshold for herd immunity for measles is very high because it is very easy to transmit measles through the air. Communities with lower levels of vaccination are seeing hospitalizations and deaths, mainly in unvaccinated members of their communities, because there's not enough vaccine use to prevent continued spread, to get those full indirect benefits. In terms of therapeutics, treatments for some infections, especially early on, can have indirect benefits from reducing the time and the intensity of the infections over a viral infection, how much virus is produced, how long it's produced, affects transmission from an infected individual to their families or coworkers or colleagues. And this often goes along with milder, shorter symptoms, which can benefit the individual, but that's not the same thing as these indirect benefits that we're talking about. And in terms of diagnostics for COVID and flu and now RSV, diagnostics enable early and pretty accurate detection of specific infections. They can be part of test to treat programs, which reduce, not only can benefit the individual through more timely and effective treatment, but reduce infection spread by reducing the viral loads and the likelihood of an individual transmitting the virus. And they may also lead to reduced spread through voluntary decisions by the people who test positive to isolate themselves or wear a mask or take other steps to reduce spread in their community. The combination of the biologic impacts of a medical product and these behavioral impacts based on good evidence, strong evidence that a product can reduce not only infection when it's transmitted, but spread, is helpful when thinking about the kinds of products that we'd like to see developed. How novel products could have benefits not only focused on how they can improve outcomes and reduce side effects or safe, effective for individuals, but how they can help through individual use better protect communities through the choices that people are making. The next slide gives an example of this. This is a hypothetical example. Let's start with vaccine A, which demonstrates significant reductions in severe infections in individuals who use the vaccine, but may only have a limited effect on reducing transmission. In this case, you're going to need a lot of use of the vaccine in order to get herd immunity, relatively high uptake of the vaccine by individuals. Contrast that with vaccine B, one that also has maybe a similar effect on reducing the risk of severe infection, but may have a greater effect on reducing transmission through preventing infections altogether or reducing the duration and consequences of even mild symptoms for transmitting the virus. In this case, herd immunity could occur at a lower level of voluntary use of the vaccine in the population. And think about combining that with these other types of technologies that are increasingly available, the diagnostic tests and therapeutics that, again, not only have benefits for individuals, enabling potentially larger reductions in severe infection rates through earlier and more effective treatment, but also additional reductions in transmission than what might be possible through vaccine use alone. And as a result, even greater infectious disease containment with less health impact on the community, despite the fact that not as much vaccination would be achieved as might be needed to get to herd immunity for vaccine A. So that's the kind of framework that we're talking about today that we wanted to get across in these opening comments. And if go to the next slide, this highlights some of the outcomes. We are focusing in this meeting on the health benefits for individuals and the indirect health effects for their communities. Would like to note that there are additional benefits beyond that, so the non-health benefits, medical system benefits from reduced burdens on healthcare providers and healthcare systems that can be stretched, otherwise would be stretched more in the event of a serious infectious disease outbreak, economic consequences from fewer cases in the community, leading to less impact on school attendance, work productivity, and things like that. And on the next slide, I want to emphasize that considering indirect benefits in policy is not new, but it also isn't yet systematic. So here are some examples, and these come from our reports on how indirect benefits have been considered in some ways. I want to focus on the indirect benefits where FDA-approved antivirals have incorporated broader indications like pre-exposure prophylactic use in communities where there are outbreaks. Again, these can reduce individual risk, but they also are a proactive way of reducing spread risk in communities where the risk of spread is relatively high. To get evidence on the label for products related to these kinds of effects. Several household trials, other analyses were needed to support these explicit prophylactic claims. Again, studies not just of the individuals using the product, but the individuals in their community and interaction, their social interaction settings. Another example is FDA's approval of respiratory syncytial virus, RSV, vaccine, monoclonal antibody that's administered during pregnancy to protect neonates. The product demonstrated minimal risk to the pregnant patient and to the neonate during pregnancy when it's administered, but then after birth, a substantial benefit of reduced risk of RSV complications for the baby. Building on these kinds of examples, our reports talk about a number of complementary avenues that FDA could pursue to more explicitly and systematically include population health benefits and support and advance studies that demonstrate these benefits. For example, the agency could provide guidance on what evidence is needed for specific types of indirect health benefits as a basis for an additional claim on the product label, one that could be used to communicate effectively with the broader public and healthcare professionals and communities about these benefits. A pre-market example might be guidance for studies that quantify and validate biomarkers of viral load or viral shedding. That's kind of an indicator that potentially means less viral transmission. But post-market guidance and real-world studies beyond the narrower clinical studies that are typically feasible in the pre-market setting could actually assess and have in some cases assessed the transmission of differences in transmission rates in communities resulting from the availability of products that are expected to have these individual benefits. FDA could also collaborate with the NIH, with the CDC, with many private organizations, health systems like HCA and others that are developing much better longitudinal data on infection risks in the populations they serve locally, and also information on these vaccines, diagnostics, and therapeutics that are being used in those individuals. Local public health organizations are getting better access to these electronic data too. That provides a stronger foundation for empirical studies to confirm these kinds of benefits. And on to the next slide, complementing these opportunities for regulatory pathways, reimbursement pathways can and could more systematically focus on indirect as well as direct benefits. Medicare Part A and Part B coverage generally requires, as we talked about, that the product fit within a specific statutory benefit category and be deemed reasonable and necessary for the diagnosis and treatment of an illness or injury. But Medicare also covers preventive services if they're reasonable and necessary for prevention or early detection of an illness and receive a grade of A or B, A/B rating from the U.S. Preventive Services Task Force. And in the context of the COVID public health emergency, Congress passed legislation mandating zero cost sharing not only for vaccines, but also CMS supported no cost availability, no out-of-pocket cost availability of diagnostic tests to help individuals determine whether they are infected and potentially capture some of those benefits that I talked about earlier from reduced the indirect benefits from reduced spread from using and acting on the results of a diagnostic test. CMS has implemented payment incentives in its quality measurement improvement program for some of these covered preventive services like influenza vaccination, noting that they have benefits to individuals, but also can help reduce risks in especially higher risk populations like Medicare beneficiaries and nursing home residents and the like, as a contributing factor to that inclusion of these payment incentives to encourage information about informed use of pneumococcal vaccination and influenza vaccination. Congress and CMS have also demonstrated consideration of indirect benefits in reimbursement in cases, but again, it's possible to make this more systematic. So on the next slide, I wanted to talk a little bit more about clarifying policy pathways to increase the impact of infectious diseases. As we've talked about, greater capacity for assessing these indirect benefits is happening as a result of improving electronic health data, better methods for developing and using this real world data to turn into reliable evidence on not just the safety and effectiveness of medical products, but potentially these indirect benefits, since these real world evidence sources are available out in the real world where people are interacting in communities and often part of local or regional data systems, as I mentioned before. And this policy shift can then help reduce the burden of infectious diseases by enabling individuals to be better informed about how their actions using these products can help reduce the spread of infectious diseases in their communities, as well as impacting their own health. So this is a brief summary, so going to the next slide, from the publications from this project. And if you want to learn more, and we'll again send some reminders in the chat during the course of this event, Here are the publications. One of these is a Health Affairs Forefront article out earlier this week. We've also published two in-depth reports available on our website on supporting evidence generation related to indirect benefits and integrating health benefits, these indirect health benefits, into biomedical product policies, regulatory policies, and coverage and reimbursement policies. And as we note in the article and the papers, this effort has benefited tremendously from major contributions by our expert collaborators who come from a range of perspectives. You'll hear from a number of them today. So with that, I'd like to transition to some further discussion on policy approaches for including indirect benefits and assessing overall population health outcomes with respect to these important infectious disease products. Very pleased, and please turn on your camera, panelists. Very pleased to be joined by Blythe Adamson, an infectious disease epidemiologist and economist, and the founder of Infectious Economics, a tremendous impact in the context of COVID and other outbreaks in recent years. And Mara Aspinall, co-founder of the Biomedical Diagnostics Master Degree Program at Arizona State University, a partner at Illumina Ventures, and a deep expert on both the private sector and public policies related to the development and effective use of diagnostic tests. So Blythe, Mara, great to have you with us today. Thank you for your help on work in this general area that we're talking about. And I'd like to turn to each of you for some opening comments, starting with Blythe.
Thank you, Mark. I'll begin with, oh, did I lose you?
Can you hear? You're still here.
Okay,
still
great.
Here and still on.
Great. Well, beginning with disclosures, as you said, I'm an employee at Flatiron Health, a real-world data company, and I also own and run Infectious Economics, and I'm affiliate professor at the University of Washington in the Comparative Health Outcomes Policy and Economics Institute. And second, I would just love to thank you, Mark, Duke-Margolis, Gates Foundation, for choosing such an important topic to invest in and dig into together as a group. So first, I would love to just tell a story to give a little more color to why I think this conversation is really needed. And it brings me back to so many memories of doing outbreak investigations at the peak of COVID. I worked with so many different employer groups, from Disney to Warby Parker, but one of the most exciting was working with the Broadway theaters to reopen the shows in New York. And it's a pretty risky transmission setting if you've ever been in one of these theaters. The dressing rooms are tiny with lots of people crammed in. There's no windows anywhere. And the orchestra pits that are underneath the stage are full of trumpet players. And so doing outbreak investigations in these high-risk transmission spaces just revealed how critical it was for the community's safety, for workplace safety, to be able to prevent as many risks of transmission as possible. And often when, someone popped positive before a show and we'd have to send them home for the night, the real question was, if there had been a magic pill that had been available for people that actually were, once they had become feeling fine, where they could just take one pill and they would be at no risk of transmitting the virus to their coworkers in the workplace, or in sending them home to the children that they were caring for, the elderly parents that were living with them, or the multiple people in tiny crammed New York City studio apartments that they lived with. But what if that medicine offered no benefit to the health of the person who took it? What if there was nothing you could do to change the course of how quickly that individual would recover? So offered no personal direct benefits to the individual. I think every single person that I sent home would have loved to take a medication that they would be able to prevent spreading this to their coworkers, return back to work faster, prevent spreading it to people within their homes. But I wonder, what is there really the right FDA framework for assessing a new medicine for when the individual who's receiving it has no direct health benefits from taking that medication, but the gift that it can give to community and society and families could be so incredibly huge. So this is why I'm excited we're having this conversation today. And we have professional societies and groups that have been thinking about this for a very long time. We have had the second panel on cost effectiveness and health and medicine really give us a directive to assess things from multiple perspectives. So looking at cost effectiveness from the patient's perspective, from the healthcare payer's perspective, and importantly, from society's perspective. This is really where you can capture both the direct and indirect benefits of a new product. But it also takes us time to be open-minded and expanding our aperture of what does evidence look like that is able to support the measurement and estimation of the benefits of these new products. And it may not always be a randomized controlled trial that is possible to be able to capture and measure those indirect benefits. But we do have now so many rich sources of real-world data, so many new novel study designs that are able to get towards the causal inference and capturing other effects. And then we also have a long history of dynamic transmission, infectious disease math modeling that is now often paired and combined with real-world data, with studies. So really thinking about what is the synthesis of evidence that is able to help us quantify what the benefit is to individuals and society together. And then my last point is I really want us to develop a system and a structure that motivates and incentivizes pharmaceutical companies to invent and discover the medicines that we want to be existing in the future. And so we need to set up, regulatory health technology assessment body. We need to make clear the pathways and clarify how these things would be measured so that it's very clear and motivating for how these new medicines could be approved if the benefits are captured differently than medicines have been reviewed in the past. And then also the reimbursement of those. Who really is expected to pay for these new medicines? If an insurance company, should an insurer pay for a medicine in the scenario I described before, where the life that they are covering is not the one that's capturing the benefit of using that medication? Is it the employer that benefits from all the people that can come back to work early and capture those days? So I think that there's just so many exciting topics for us to dig into today, and I'll leave it there and pass it on for more discussion. Thanks, Mark.
Great. Well, lots to follow up on. Thanks very much, Blythe, and thanks for all that firsthand real world experience. Broadway does sound like a high transmission, not to mention high stakes environment. Mara, can I turn to you now?
Yes, this is great. And I will just reiterate, it's terrific to be here on this important topic. I'm going to look back before I look forward. So, Mark, as you know, we worked with Duke-Margolis and the Rockefeller Foundation around the diagnostic aspects of COVID. And I think it's very important to understand what happened there and what the evolution does. And it really reiterates the points that you started with. There's direct benefit, but what we're focused on today is indirect benefit. So I'm going to share one slide. So if the team would put up a slide to underscore that and really talk about the core of diagnostics. Now, granted, I might be a little bit biased here, but I'm going to make the strong statement that diagnostics are critical. They are the glue holding clinical medicine together. And whether it's pandemic or not, or just infectious disease, as you said earlier, Mark, identifying those people who are either sick, soon to be sick, or infectious, even if they have no symptoms, is critical for the community. So in the Broadway example, whether it's the people on the stage, but frankly, even the audience at the height of diseases that are highly infectious. So let's again look back and start with diagnostics for COVID and underscoring this, how important and essential they were for every aspect of COVID. And I'm going to argue even today, 5 years in a week beyond the beginning of COVID, or at least in the US. So next. What you'll see here is at the very beginning of COVID, we as a broad society, this was mostly happening in China, we're starting with just symptomatic diagnosis. The only people who were diagnosed were those who had aggressive symptoms and in many ways, a diagnosis of exclusion that didn't have at the time what we thought was regular pneumonia. It then moved to active disease diagnosis across the world and then screening. And I would say now we are in an area of surveillance. Some countries more than others, some communities more than others, but we've moved to surveillance. And what you'll see throughout this slide, remember the word evolution, the importance of change and evolution of the diagnostics, or really, frankly, testing. So next. So where did that kind of testing happen? Well, where on the body? It started with hugely invasive testing, that symptomatic DX. It was done, was what's called a BAL, essentially a biopsy of the lungs. It moved to semi-invasive, my favorite phrase, tickling the brain. And it wasn't that bad, but not pleasant. But then most importantly, it moved to minimally invasive, just the front of the nose, and now to non-invasive with saliva. And I'm going to argue really from a formal testing, direct, it was all about saliva. But as we continue to move forward, next is the fact that it's changing again. And it changed from the hospitals to the central lab to point of care to the home, or what I call point of need. And what do I mean by that point of need? It's not just about the individual. It's what we're talking about today. It's about indirect. It's about monitoring the air in a school, in a hospital, in an assisted living facility, in an airplane. It is looking at that from the breath that we exhale. Very few people focused on the fact that towards the end of the most active part of the pandemic, the FDA approved a test that was done from VOCs from breath. It was not broadly commercialized, but the question is, it works. So this all sounds very good, and lots of people say, yeah, terrific, but how practical is it? So next, it's always important to look at the cost, from thousands to hundreds to tens, and now at retail, it's probably closer to $10, but I believe that we will see COVID tests and other infectious disease tests, which I'll come to in a moment, being in the single dollar amount. There's no reason at scale that they are not like, I can show it on my screen, a pregnancy test, which you can buy at the dollar store for $1 or $1.25. Ultimately, these tests that you can do at home are called lateral flow tests, which you're probably all familiar, are very successful, and they will be affordable to maybe not all, but many Americans and others around the world. These are the ones that make a huge difference on a broad scale. What I'll just add before concluding my overview is that in the midst of a lot of people wanting to put the pandemic behind us, is not a lot of focus on what the FDA did in 2024. And I have a report coming out in a newsletter about this. But what the FDA did is approve 8 home tests that for the very first time are flu A, flu B, as well as COVID. And while these tests are at retail between $10 and $20 a test, not quite affordable to everyone on a regular basis, this is a huge watershed to have that direct testing available and ultimately help that on an indirect basis. The other thing that's happened is that close to 20% of all municipalities are continuing to test for COVID and other infectious diseases in their wastewater, which could be one of the most cost-effective ways to get that indirect benefit. And we saw that a lot over the pandemic, whether it's a college campus, a senior living facility, where we could track an outbreak and deal with it there without having the entire population take precautions or new steps. So it's about, I think the irony here, I think about it as an upside down triangle. It's about going broad to be able to go specific and not impacting the rest of the population, but still making us all healthier. So with that, I look forward to our discussion.
Great. Well, thank you very much, both of you, for a lot of concrete examples about, as you said, looking at the past, but looking ahead to the future. We do have in there up on the screen right now some pretty broad discussion questions that we've shared beforehand. I would like to remind those of you who are with us, if you have a question that you'd like to add to this discussion, please use the Q&A function in Zoom to get that to us, and we'll try to get to those as well. But let me start with the first question here, and both of you touched on this a bit. As you talked about, there are a lot of assessments that are used for medical products themselves, and assessments that have been used in contexts, Blythe, real world contexts like Broadway or other settings where there's kind of a lot of interaction between potentially infected individuals. Where are we in terms of being able to use these existing technology assessment methods? Are there any particularly promising ones that are perhaps underused now or up and coming to something that policymakers, including the leadership at FDA, CMS, these other federal agencies should be focusing on? Blythe, you want to start?
Thanks, Mark. Well, I think that, so I work very closly with many of the European health technology assessment bodies. And right now, everyone's talking about UNETA, which is the joint clinical assessments now of regulatory and HTA bodies. And all the conversations revolving around PICOs, the patients, like what population, intervention, comparator outcomes. And it's really interesting to see, to think for these types of assessments, when you're trying to capture spillover benefits, you have to so clearly define what population you're looking at, because the spillover benefit depends on what population is receiving this medication or vaccine or intervention. So first, I'd say, when designing some of these studies, whether it's a real world data study or a modeling study, the first thing is very clearly defining the population. Some of the studies I read, I think, are misleading when they do their estimations and modeling in very, very high risk populations and then extrapolate the same magnitude of community benefit to lower risk populations. So I think that this is something that needs to be agreed upon upfront of who really is indicated to take this, what's the broader population that you think can capture benefit from it. So I think it's been really helpful to see that play out in Europe, of how now they're very clearly enumerating all the populations that they want to see measured and describing the risks and benefits for trade-off. And then I'd also say, considering the time horizon is one other aspect of it, because it will be very different if you said, what's the indirect benefit that's going to be captured over the next 6 months if this population is going to receive this drug vaccine, or what's the benefit in 5 years or in 10 years? Because we know that the benefits are usually grow and grow and grow over time. So being able to weigh the risks to an individual person with the benefits that are captured at a population have to also include this time dependent factor of, how long are you willing to wait for benefits to be captured that outweigh the risks to an individual?
And in terms of what you're seeing now, I get the point about how different the at-risk populations may be for these indirect benefits and the importance of having models that account for those differences, for that heterogeneity. I know you've done a lot of, as you mentioned before, the dynamic modeling, which I appreciate how you summarize that work. The way I think about it is trying to think through a kind of a thoughtful logic model of, okay, how does the burden of infectious disease occur through interventions that happen or not at the individual level and then through their interactions over time. That can get pretty complicated, but that's just the nature of these, diverse communities and interactions that people have. Whereas what we're typically able to study in an empirical analysis is, maybe one particular population at one point in time or a limited time period, or as I mentioned before, even in the pre-market setting, there often are studies of viral loads. Does a nasal vaccine reduce nasal viral production better than others, might indicate an indirect benefit. Where are we in the how do you think of putting these pieces together, and how can we make it a more comprehensive and feasible and compelling whole framework?
Oh, I'm so glad you asked that. If it's okay for me to jump into how
Yeah.
modeling can be so useful here. Now, I'm not talking about using infectious disease models here for forecasting and prediction of the future. They're really useful for understanding the comparator and the incremental difference between using this product in a specific population under an assumed rate of utilization versus if that product didn't exist on the market. So really, the models need to be complex enough to include the mechanism of how that benefit to the community will occur. So sometimes they do have to include that layer of like a social mixing matrix to understand, how many contacts people have every single day and the probability of transmission in each one. But they're really an incredible tool to say, okay, for this population, this cohort of individuals, this employee group or this city, here are the outcomes that we see, the health outcomes and maybe other enumerated types of economic outcomes for this population if this drug was available versus if it wasn't available, and allowing us to say, to then look at that incremental difference and say, is that worth the risk of trade-offs
Mhm.
of uncertainty in some areas?
And the models are, and I know you just described, the sound. I know this must sound complicated to a lot of people, but it is a pretty well developed science now. But it also depends on the data that you're putting in, right? Like defining or you might say the parameters for how big of a risk reduction might be, what an impact of a particular technology might be, not just on the individual, but on the rate of spread. Do the models help you get a sense of where the most important empirical questions remain? And have you seen sort of progress in using modeling to really strengthen the empirical evidence base too?
Absolutely. I mean, even when I was working at the White House in the West Wing and I was building a lot of these models to make policy decisions, it was the uncertainty in different inputs to the models that would allow decision makers to see how the conclusions could swing to one direction or another, and then be able to sort of rank sort, here's the things that you may be really uncertain about, but they actually wouldn't change your decision about what to do at the end of the day. And there may be some other small minor things like how many days is someone on a ventilator, where the uncertainty in that actually could radically change your decision about what to do. So I think that even though the models are complex, there are ways that you can use them and use the inputs to identify where are the areas of uncertainty that if we shrunk that down by doing another study or by analyzing real world data, would that give us the ability to have confidence that we're making the right policy coverage approval decision?
And Mara, if I could turn to you, maybe focus on diagnostics, where you've done so much work. Can you say a little bit more about sort of the state of the technology assessments, the state of the real world evidence that helps lead to the same kind of informed decisions about benefits for others, benefits to individuals in the diagnostic context?
Sure. So I'll start from an individual perspective. The good, I think it's a little bit of bad, but mostly good news is that the home tests that everybody had during the pandemic are still effective, and towards COVID. But if we
Mhm.
move forward, what has been great, because if you had said, could you do a lateral flow test, and produce it for a couple of dollars, send it out, and have individuals in their homes from age, 7 to, well, I'll say 8 to 80, but really more than that, nobody would have believed that it was possible. So the good news is that works. It's been useful on and shown that it can work on many, many more diseases or pathogens. Some may be more complicated and we may need more complex technologies, but let's go with the basics here. So that's number one. Number two is, what are the cutting edge technologies? And here is where the breath and saliva has been accepted, but very difficult to do at home because there are a number of challenges that, frankly, your mouth has a lot of different bacteria on it. So doing that on a home test gets very difficult. But on a population level, very much still effective. But I think the game changes when you have breath tests that can be analyzed in real time. And I believe that as a venture capitalist, I've seen several companies that are not quite ready for prime time, but I believe that we will see companies who have the ability to either take the fluid out of your breath, so it'll take more than a minute, but most recently take the fluid out of your breath, use that essentially as the analyte to be able to look for infectious disease. I think the key here, though, I talked about the difference between diagnosis and monitoring, but there's a more fundamental difference here, is can we create as a society a test that says sick or not sick, even if it doesn't have the specifics of what the pathogen is? And during COVID, that was not relevant because we wanted to know whether it was that disease or not. But going forward, can we expand that and have almost a new category of tests that just monitors illness or not illness, and those who then have some sort of pathogen going on, and it's more than just fever, to then move on to a more specific test. So that's for an individual direct level. But if we look at the indirect level, I want to come back to wastewater because the cost effectiveness of that is less than a penny per person. I talked about 20% before, but 80% of homes are connected to some sort of municipal system. There are about 1,300 sites who were part of that, and about 130 million people did they actively cover. That, I believe, can be the most effective way to do indirect sampling. But the key, which has not happened in a broad way, is taking it to then communicate what's happening to the people in those communities, and potentially down to individual businesses, homes, or multi-unit facilities, to say, we're detecting disease here, and then only raise the threat level in those places. But I think there's one other piece. So that is wastewater, which is continuing and I believe can be highly effective, and frankly needs to be. The last piece, which we haven't talked about, is just data itself, and not, no offense, Blythe, but with a complex model, but a relatively simple model. Google did and Google does at the beginning of each flu season, to look at searches, to be able to look at what are the diseases that are coming in, what are the ailments that are coming in to an individual emergency department, to say what is happening in one community versus the next community. And doing that on a zip code or SMSA basis can inform public health, continue to have individual privacy, and feed the models in a highly effective way. But the core to that again, is the communication from the systems to know what's happening in that ED, and then moving that to decision makers in a community. And that's the piece that I believe can be effectively done in our current environment in a way that protects the privacy, but still moves to an area that is has indirect benefit on a public health perspective.
I would like to maybe pick up on some of this. One of our other discussion questions gets to sort of value proposition for stakeholders, and maybe Mara, staying with you for a minute. You mentioned sick or not sick test, which by itself might not be that informative in terms of at least individual benefits, but could lead to a more specific test afterwards. But sick or not sick, or maybe contagious or not,
Yeah.
would be very helpful for at least some individual informing some individual choices about what they might or might not want to do given impacts on others. Do we have the incentives in place to the value proposition for product developers and for people who might work with product developers to figure out whether these approaches really are effective or not? Do you see gaps there?
Yeah, big gaps there. I mean, there's always been a gap in what's called the valley of death from that early stage development that universities or other researchers have a bright idea, people like it, they get a couple of $1 million. And then when you know it works, lots of people are lining up to give you money. But the valley of death in between, I think, is very distinct here, particularly with the prospect that the federal government may not be a core funder. So one of the things that was clear during COVID is that governments and municipalities were the primary purchaser of many of the diagnostics. I think that's why the economics has to be looked at the very beginning. And I'm intrigued again with wastewater and breath detection. Yes, dogs work too, but frankly, it seems very cheap to take a dog to an airport, but it's not clear that it takes 6 months and very specialized handlers to train that dog to do what they're doing in the few minutes. So I think the challenge is indeed putting enough money and incentives in the early stage. From a venture capital point of view, diagnostics has been a real challenging area. If you look at the vast majority of the companies that had EUAs under COVID and sold several $1 million worth of tests to corporations, governments in the US, around the world, in my count, there are less than a dozen that still exist. And many of the ones that were sold at rock bottom prices. So what I would say that we need in terms of incentive is some of the work that you and CPATH and others are doing is pre-competitive space to see if we can leverage the scientific insights in an organized way to work together so the economics work going forward. And understand, as we did during COVID, in a large way, understand the pathology of a disease, the natural history of it very quickly, to be able to point companies with relevant technologies to do it quickly. I think that becomes fundable, but without that, for an individual companies or in COVID to have lots of people repeating the same kind of science is very challenging in the current environment.
Yeah. Blythe, any comments that you'd like to make on incentives and value proposition for developing these products that have important indirect benefits? So Mara's focused on diagnostics. Could add to that, or your thoughts on the vaccine or therapeutic side as well.
Yeah, I think it's just good to first acknowledge that the value proposition is so different for diagnostics, for vaccines, and for treatments. We really have to think about them differently. And with diagnostics, as you said, the value doesn't come from just the result of the test. The value is captured by the action taken with that knowledge. And so who's really capturing the value from that? As she was describing with wastewater or with measuring air samples. When it's done at an institutional level or at a facility level, it's interesting to think who's really capturing the value there, because they should be incentivized to be willing to put in and contribute funding to be able to have the information they need to make a decision and capture value from it. So diagnostics, I think, are a tougher space than we're in with vaccines and with treatments, where I think it's actually easier to describe the spillover benefits and measure them to the specific community. Yeah.
Mm-hmm. And I think something that both of you have emphasized, and maybe I'll stick with this, and we've got by the way, some good discussions in the good questions in the in the chat that I'd like to get to as well. But just following up on it seems like what's very important is for there's the characteristics of the product itself, how much benefit and risk it might provide for you individually. But as you all pointed out, the characteristics in your community matter a lot too. How good are we? Let's say we've got evidence on what the safety effectiveness profile of a vaccine or treatment might be, or the profile of a diagnostic test. How good are we at getting from that evidence to information that people can actually use as they're making decisions, both about their own health benefits and risks, and the potential benefits and benefits to others based on using the product?
Yeah, I'll start with that one, and also, I'm sorry.
No, I was just saying that's probably the toughest question he's asked so far. So please.
Yeah.
We're getting towards the end.
That's right. But I think we're all saying, we've actually said the same thing. It is about the communication and what I call, what is the best test? The so what test. And maybe the most important one is, what do we do with the information? So what? What changes as a result of that, both direct and indirect? And as some of the questions ask about how do we create tests, in this case, tests that have a minimum of burdensome interaction and a maximum of help. To me, this transmissibility test, if it exists, which it doesn't, as far as I know now, the sick or not test might be a bit easier, because the reality is you're dealing with a lot of different pathogens. So you can't design, at least to date, a generic test that does that everywhere. Could you use wearables, which Jessalyn asked? I've looked at a bunch of these. I don't believe they're effective enough now. They weren't in the past, and I haven't seen one that could be relevant in the future in an infectious disease sense. But could you use it when, like Switzerland did, during an outbreak? Absolutely. But it's the core of creating the foundation of information first, and have people willing to disseminate it. But I think the key issue, and Mark, you alluded to this at the beginning, is it doesn't have to be everybody. Is an effective system can go one way or another. It can go to just high-risk individuals, and therefore have a huge societal, direct, indirect, and economic benefit to high-risk individuals, which will change a little bit depending on the pathogen. But it could also go to those who are interested in a community, and then have word spread in a more informal way. And I think we've seen that in a lot of outbreaks, that it is effective and it does work. So that for me is the core of doing it, but it's just as much the information technology as it is the biomedical technology.
Yeah. And like you started out talking about how, based on your direct experience, how much people, especially people working together in close communities, care about the impact of their health or their transmission on others, and wanted good information on it. Are we developing and translating that evidence into messages, communication that people can use effectively now? There's a lot of sources of information out there, especially around infectious diseases these days.
We should be. as Americans, we love our freedoms. We want our individual choice. People don't like being told what to do. And I think that it is very difficult messaging to ask people to do something because it's going to benefit their neighbor. They want to know how much it's going to benefit themselves. But I would argue from my first example that there are many other reasons why benefiting the people around you benefits you back, going back to work, taking care of your family, just having a healthier, happier community. But it is more difficult. It's very different in Europe and in other countries where the government can just make a policy and it can apply to everyone and people will comply and follow instructions. And we are just in a very different set of societal values. And it's something that we need to navigate together so that we can understand and estimate what is the value of this novel product to society, to our American society, and measure that with new trials and real world data and modeling, but then also provide the right information to individuals and providers in their conversations so that they can be able to make a decision. And one other thing that I'll say, Mark, you didn't ask this, but I think it's important.
That's okay.
Is that
Or at that point in the session, Mary,
yeah,
you too. If there's
when
some
we're
things that I
measuring,
should have asked but didn't,
yeah,
I'm
no,
going to
no,
you next.
so different than many other classes of medicines, the effectiveness in reducing transmission is probably going to be changing over time, likely waning over time. And so we can't just think of this as a static one-time assessment and approval. We are likely, for many of these things, going to need ongoing monitoring and real-world data collection and the right public health data infrastructure so that we can see, are these things still working? Or are we just doing things that aren't even helping our communities anymore because something approved 5 years ago worked with the circulating viruses 5 years ago, but they're not really very helpful with what's circulating today. But I'm really hopeful because the cost of building data infrastructure now, public health data, even private health data, is the marginal cost of production is getting smaller and smaller now because of all these technology innovations. And the way that I'm seeing LLMs and other techniques being used to rapidly curate data at very low cost in real time gives me so much hope that it's possible for us to design systems like this in the future, to approve drugs, vaccines, diagnostics, and be able to, over the longer term, measure how well are they still working? Are we still capturing the returns to make it better than the trade-off?
I mean, it does seem like most of that evidence, even in the short term, for these indirect benefits for others is going to come from the real world settings that you're alluding to, and not to mention the changing profiles of effectiveness of products over time and the changing benefit risks as community conditions change, something that you all emphasize. All of those are areas where you all noted that the data are getting better, but maybe we're not quite as systematic as we could be. It is interesting that the new administration has put a very high priority on interoperability of data that people can use to make more informed decisions about their health, and that a lot of support, and certainly in the healthcare community, for making such electronic data more shareable, protected and individually protected, but helpful for informing about benefits and risks of products, and also benefits and risks of these indirect benefits. Mara, I want to turn to you. We've only got a minute or so left. Any final thoughts that we can pick up on in the rest of our discussions today?
Yeah, I think the coordination and communication within the healthcare environment is the first piece. So I talked about the ED before, and there's a question you just spoke about electronic data records. That has to be the first piece. And there are a lot of holes in that system. So to be able to have a system that is truly seamless, even though we have a multi-payer system in the US, I think it is a critical piece, and maybe we can learn some lessons from that, from single payer effective systems. Number two is the ability to use AI, but in an organized way. so that we're still using the data and the LLM models, but checking that to ensure that it's still reality. And then lastly, where I started, it is about evolution. We can't assume, and I think everybody's mentioned this, that the drug that works today, or even the vaccine, and certainly the test, will continue to be effective across the time frame of, forget pandemic, just epidemic or explosion of disease in one community. And then in order to bring that into reality, we have to be doing education of our healthcare providers and not assume that they're all coming to it with the same background. And that to me is MDs, but many more healthcare practitioners in the broadest way. Although Mark, you're making a face like, does that not make sense?
No, it
Oh,
absolutely makes sense. I'm just thinking about how I'm going to ask the upcoming panels about it,
okay.
since we are turning towards more of a focus on evidence. And but for now, I want to thank you all for an excellent discussion of a complex set of topics, and getting from the complexity to some practical examples, both in the past and some clear opportunities going forward for putting these pieces together to get from the way that we typically think about infectious disease products from individuals at a point in time to these very important benefits that people care about if they can get reliable evidence on them about impacts on their community. Thank you all for kicking us off so well. I want to thank also our attendees today for a number of questions, many of which you all were able to answer in the course of this discussion, and others that we'll come back to. So for those of you attending today, please keep the questions coming. Right now, Blythe, Mara, thank you so much for the work you've done with us leading up to this event, and for the excellent discussion to kick us off today.
Thank you.
Thank you for having me.
And next, I'd like to turn to our second session of the day, which is going to dive deeper into ways to generate evidence on the indirect benefits of infectious disease products. This session is going to build off that report that we recently issued on supporting evidence generation on indirect benefits and risks for medical products used for infectious diseases. That paper reviews a range of sources of evidence, many of which our panelists just touched on, to assess indirect benefits, and identifies ways to better capture those benefits, and provides a description of some further steps to encourage evidence generation on indirect benefits, and also for connecting to policy recommendations for federal agencies to help support that evidence generation. We touched on some of those issues in this past session. And going on to the next slide, this paper reviews the relevant work on how to develop evidence on direct and indirect benefits. This is another way of summarizing that. If you thinking of medical products that are used for infectious diseases, that second row about individual health outcomes has implications both for direct and indirect. Reducing the risk of infection, say through a vaccine, has both direct benefits to the individual, depending on their own risk of complications from that infection, but benefits to others. If an individual isn't infected, they're not going to pass it along to anybody else. So indirect benefits for people who may be at higher or lower risk through the community exposure, the interactions of that individual with people around them. These products, as we've talked about, may also have impacts on reducing severity of disease that can also reduce spread, as well as prevent serious complications that are valued by individuals. Beyond that, may also have additional impacts on reducing risk of transmission, which we talked about how important it could be to measure transmission risk more accurately to help assess these issues. The clinical trials that are typically done for approving these products focus on the direct benefits. That's kind of easiest to measure when you're looking at a set of individuals who are given the product versus those who don't. But In the context of the indirect benefits, it's important to consider the community and the exposures for which that individual might have contacts that where transmission could be effective, and that's more challenging to do in a clinical trial. As Blythe mentioned, there certainly is modeling that would suggest, based on things you can observe in a clinical trial, like risk of infection and maybe some of these markers for whether or not a person is likely to transmit, like their viral load. Those things are indicators, but really this is where real world evidence in a range of settings, which are increasingly feasible to develop, could be quite helpful. So putting together the dynamic modeling with the real world evidence is a big part of what we describe in this report. And that in the end leads to the better evidence on direct benefits, on indirect benefits, and overall health benefits from the medical products. So that's the framework described in this empirical oriented paper. I'd now like to go on to the next slide, welcome our next set of panelists to the discussion, and very pleased to have with us, and please turn on your screens if you haven't already, Natalie Dean, Associate Professor in the Department of Biostatistics and Bioinformatics at Emory's Rollins School of Public Health. Dr. Peter Marks. Peter, thank you for taking the time. You've got a very busy full-time policy job right now as Director of the Center for Biologics Evaluation and Research at the FDA. And Susan Sabalev, who's President and Chief Operating Officer for RIG Immune, which develops products in this space. And Susan, I'll let you talk a little bit more about that as we get going. So I'd like to turn to each of you for some opening comments around measuring and developing empirical evidence on indirect vaccine effects and any related topics that you'd like to bring up for the good of this panel. So Natalie, to you first.
Great, thanks. So I'm Natalie Dean, Associate Professor at Rollins in the Department of Biostats and Bioinformatics, and then also the joint appointment in epidemiology. And my research focuses on the design and analysis of studies to evaluate infectious disease interventions, especially vaccines. Previously worked on vaccines against Ebola, influenza, chikungunya, COVID-19, and have non-vaccine work on dengue, HIV, and Zika. And for disclosures, I currently work on a DoD grant awarded to Bavarian Nordic for their chikungunya vaccine, and I'm a member of the steering committee for Janssen's Ebola vaccine, and I've worked with Emergent Biosolutions on their Lassa fever vaccine. So I've been fortunate to train with folks like Betts Halloran and Ira Longini, who are really leaders, wrote a whole book on the design and analysis of vaccine studies, including how we rigorously define these concepts like indirect vaccine effectiveness. And I'm going to use my time to discuss kind of what may feel a little basic, but I just really like to step through these concepts of what it means for indirect protection for vaccines and some of the key study designs to achieve this. And I'm a very visual learner, so we're going to use a diagram for this. So first, as Marcus pointed out, vaccines can provide a direct benefit to individuals by preventing infection. And that's demonstrated here in this picture. We have unvaccinated individuals and vaccinated individuals, and you can see the red are infected, the white are not. And so here in this example, the vaccine has averted 50% of infection. So that provides a direct benefit to those individuals, but also will provide a source of indirect benefit. Can you go to advanced one? Yeah, perfect, thanks. So actually, can you advance to another one? Great, thank you. So, that provides an indirect benefit, because when we think then about the people around those individuals, the people who are infected can go on to transmit to their contacts, their household members, and so on. Whereas the people who are never infected obviously cannot go on to transmit. So that's one source. So the ability for a vaccine to prevent infection is one main line of evidence that we use for indirect benefits. But it's not the only line of evidence. And so what I've demonstrated here with how many little red people are red is that in the vaccinated case, I have fewer individuals who are going on to become secondary infections for the vaccinated cases versus the unvaccinated cases. And so that's when we talk about someone becoming less infectious. That's another contributor to indirect protection. And that can occur if someone has less viral load, if they're infectious for a shorter period of time, if they have fewer of the symptoms that, like coughing, sneezing, vomiting, whatever, that are a way that the disease transmits, the pathogen transmits. So that's the other sort of piece of the puzzle, is how infectious those cases are. Can you go to the next slide? So when we think about studies, we have, for example, individually randomized trials is really the main source of evidence about the direct protection that a vaccine provides. These can also provide information. It's not always measured, but sometimes measured how much a vaccine prevents infection. So that's sort of can be built in there. But when we think about ways to then also generate an evidence base about indirect effects, something that has been explored and done a little bit is, the adding on studies that look at the contacts of individuals in those trials. So adding on like household studies that look at these household members, and you can kind of compare how many secondary infections are there for the household context of the vaccinated folks versus the household context of the unvaccinated folks. It gets more complicated, but that's one sort of way you can generate evidence. Okay, next slide, please. So another thing that's been mentioned is about biomarkers. And so the basic idea there is you may not be able to directly observe those secondary infections and follow those contacts. But if you feel comfortable inferring that, okay, a reduction in viral load by this much, it indicates that there's a reduction in transmission, you can start to link in with the models how much you think that indirect benefit will be. So if there's a lower viral load, shorter duration of infection, or these other things that you can validate, that's another line of evidence. And then last slide. And then finally, I'll just flag that there are other, so not all studies of households are randomized studies. And one major line of evidence for COVID, for indirect protection for COVID, was from household studies. Observational studies, often they leverage healthcare networks or some sort of situation where you have the households well observed and you can look and see when people get sick. Otherwise, they can be quite expensive. But those, if you can reasonably try and adjust for differences between those vaccinated and unvaccinated individuals, adjust for those confounders, you can infer something about transmission. And then finally, not used so often, well, used sometimes as a phase 4 kind of study or cluster randomized trials that look at sort of at the community level, how much a vaccine is reducing transmission within that community or protecting individuals within that community who are unable to be vaccinated, they're ineligible, or so I'm hoping that this helps frame the discussion as we move forward, and I'll stop there.
Great. Thanks very much, Natalie. And I come back to you on some of what we're finding and how we can do it better, especially as we talked about in the last panel, what does the future hold for making these kinds of non-randomized but still useful, more real world studies easier. But thank you for some great opening comments. Peter, turning to you. And thanks again for joining.
Thanks very much. I appreciate it. I think that was probably as good as it's going to get, but I'll try to say that from a couple of things, from the standpoint of FDA, as we think about trials here, we're looking to have evidence that helps us get things off to a good start, which means that although we are not responsible for deployment of vaccines, we can help generate the evidence that will get them off to a good start, which means trial designs can potentially incorporate looking at the effect of a vaccine on transmission. We know that for certain infectious diseases, vaccines do a very good job or did a good job at preventing transmission, which a good example of that was the older pertussis vaccine, great example of a vaccine which both prevented disease and prevented the transmission of the infectious agent. We know that, for instance, the first generation COVID-19 vaccines did not do a terrible job. They had 40–50% reduction in transmission, but subsequently that fell off practically to zero. Or close to it. So we do have, this desire to try to have a combination of ideally of direct benefit and indirect benefit baked into the vaccines. It's just that it's so much more expensive often to get the data that one needs when one's developing a vaccine about the prevention of transmission. That's because when you're developing a vaccine, it's much easier to look at individual surrogates of protection or correlates of protection, such as antibody levels in an individual or the prevention of disease in a given individual than in household contexts, et cetera. When this was suggested, for instance, during COVID-19, that a study be done that would look at formally look at the interruption of transmission, the cost became just insurmountable. And so unless you had a particular population that you could use that was at risk, for instance, college students or those in a military population in a given closed location, it's very hard to imagine that. But I think as we move forward, we need to think about generating this kind of evidence, because we are going to need compelling evidence to help people feel convinced that vaccination is good for themselves, but also for their communities. And having that kind of information may be helpful. I just want to also just back up and say that by definition, when we're developing vaccines for broad use, one of their direct benefits has to be that they are very safe medical products, okay? That just goes without saying, because that goes to getting acceptance of people, both for their individual direct benefit as well as potentially for the indirect benefit, right? If you have an intervention that you can do that provides you with a good degree of safety personally, but then it can help others, you'll tend to do it. We hope that's why people wear seatbelts, et cetera, right? Because things like that, where there's the cost of this in terms of potential adverse effects is very low. We by design make sure that's the case with any vaccines that are approved. And I think that's also one of the issues that factors into this whole equation of whether you have individual benefit as well as societal benefit from the vaccines that we deploy. At the end of the day, I think the case here is a really interesting one, because when you look at the cost of deploying a vaccine, if you can interrupt transmission, you get even more cost benefit from it, right? And that's why the effectiveness of measles vaccine, when you have a high rate of measles vaccination, in other words, measles vaccine with measles vaccination rates over 95%, is an incredibly cost-effective. It's usually rated among, this is public health when it gets to its best, right? Low-cost medical product given twice early in life, when you have at high coverage rates, leads to the abrogation of a potentially deadly disease. That's a good thing, right? That kills at a rate of about 1 in 1,000. This is, I think, how we have to be thinking here. Highly safe medical products deployed, and how we generate the evidence, though, going forward is going to be critical, because I heard this earlier on loud and clear, and I have now experienced it. Vaccine mandates are not going to get us there, right? It's going to be compelling evidence. And it's going to be compelling evidence both for vaccine effectiveness for the individual and potentially for the community, as well as compelling evidence that the vaccines are safe for the individual. Now, it's up to people much smarter than me about how we're going to end up commuting and communicating through some layers that would seem to not want to accept that vaccination is the public health triumph that it is. And I won't say more about that because I'd like to keep coming. I'd like to be able to come back to this desk tomorrow morning. It's a nice desk. But we do have to think about this because at the end of the day, I can guarantee you that sometime in the next 10 or 20 years, we're going to have another infectious threat that's going to come across this country. And if we cannot get the kind of confidence both in the individual and in the societal benefits of vaccination, we are going to unnecessarily lose at least tens of thousands of American lives, whether it's influenza, another wave of a novel COVID, or disease X. And so I think this is why we've got to get this right, both for the direct, indirect benefit. I'll stop there.
Well, I really appreciate your comments. Really glad you're at that desk at FDA. If I could ask this one, and we're going to come back to how we get this evidence better and how to communicate about that. But I mentioned before the RSV vaccine. So, and Blythe in the previous panel said, what about a product that might have very limited benefits for an individual? Every product has risk, as you mentioned. Vaccines are extensively tested in huge populations, and we'll come back later to the, to the post-market evidence systems that are continuing to get better and better too. But every product has, some small risk associated with it, very well defined. What about these products like the RSV vaccine? It's not going to do much for the mom, very low risk of complications from RSV, but it could do a lot for the neonate. I know you weren't directly involved in that decision, but you provide any context for how FDA thinks about that kind of case where there could be significant indirect benefits from a product use, which goes to kind of the core of some of the issues we're talking about here today.
Yeah. I think Mark, that goes directly back to this benefit risk calculation. If and you said it already, the risk is low enough to the mother, right? Low enough to the neonate, in other words, very low rate of that's why we were obsessed. There was an obsession about rates of miscarriage or anything that could be that could upset the risk calculus. But otherwise, to have something that is a relatively easy intervention, right, that doesn't involve having to give a newborn an infusion of something, an injection or infusion, quite a nice thing to be able to have, right? Whether it be for Tdap or RSV, things that can provide a neonate with protection against something that's life-threatening. And somehow we've seemed to have missed that. In the olden days, there was like life years that we used to calculate often, right? Saved. If you save a 6-month-old from death, you've got a lot of life years that you've added, right? And so I think we need to, this concept of, well, there are only a couple of deaths that occur from COVID or a couple of deaths from influenza. You've been watching children, and having interacted with families that have lost children to infectious diseases. It's just, it breaks the whole family. So yeah. I think we need to be thinking, not that it's any better for an older family, older person, but I do think we need to think about this. And the way we get there, Mark, is I think we set that risk tolerance as very, risk averse. It means we demand a lot of our vaccine candidates. I feel
and a lot of that direct evidence that we're talking about that's already built into the clinical trials for getting to approval. Yeah.
Yeah, and it does mean that sometimes we're going to kick out candidates that if they're not safe enough. Now, remember that this risk calculus shifts, right? So if suddenly somehow we had I'm just going to make up a hypothetical. The Ebola Kansas strain suddenly. Sorry, didn't mean to pick on any place, but
no news
you know,
here.
and there was a 25%
Yeah.
mortality,
Yeah.
and you had a vaccine that caused, you
Mhm.
know, caused
Yeah.
an incidence of GBS or something of 1 in 10,000 or 1 in 100,000. You'd say, nope, sorry, we're going to deploy. Right, we
Mhm.
shift that risk calculus based on the threat, but and this has to be this risk calculus is something that also seems to get lost, because what has happened is for vaccines, we are continually focusing now only on adverse events and not on benefits, and I think that's because of the success we've had with vaccines.
Yeah.
Measles vaccine is an incredible victim of its success, but if you want to see what happens when you don't have measles vaccine, you don't have to go very far. Just take a trip to Africa and Asia, and you can see what happens when you don't have measles vaccine.
Yeah.
You have
And we're going to come back to
129,000 deaths in a year.
And we're going to come back to some of the real world evidence, even here in the U.S., that's relevant to questions like that. So thanks for those comments. A lot there. Susan, like to turn to you next.
Sure. Thanks, Mark. And completely supportive of vaccines. I'm going to tell you a little bit about what we're working on at Brigham because I think it gives a perspective of developing a therapeutic. What we have developed is a synthetic RNA that actually mimics viral RNA. It activates RIG-I, innate immune pattern recognition receptor that's in the cytosol. It's really sort of viewed as the first line of defense. In this topic of transmission prevention, we've been able to generate pan-viral data in many different types of viruses: influenza, RSV, SARS, COVID, parainfluenza, excuse me, rhinovirus, Rift Valley fever, and Ebola, because we're activating the innate immune system. We've also developed it as an intranasal formulation, non-LNP, because we have an understanding of the stability. And that way we're delivering it to both activate the mucosal immunity as well as the innate immunity systemically and generate. We look at and think about biomarkers. So when we think about some of the indirect data, when we think about diagnostics, we talk about a lot, we've been talking about actually looking at the virus. We're thinking about it from our design of clinical trials slightly differently. That may also have an application in the indirect method. Because we're activating the innate immune system, we're activating the interferon pathway, the interferon stimulating genes, which is, of course, are part of, killing off the virus. We're wondering if the data that gets generated could help understand, can you use a biomarker that you could get a nasal biomarker to start with that actually may tell you in advance of having the virus that your body has been exposed, and you can, think about ways to benefit there. The next part of our story, so we have a very safe molecule, it's ready to go into the clinic, but we had to think about how do we take it into the clinic to generate an indication that we view as commercially viable, because that's part of investment in companies, right? There, people have to see the commercial opportunity. We were really fortunate when we started thinking about the clinical trial development for our molecule occurring in 2023, where we had this tremendous amount of data that had come out around epidemiology of what happened, what it looked like to have the amount of viral respiratory diseases, say, prior to COVID, and then what happened with COVID with all the non-interventional mask wearing types of things. And what we saw is a complete depression or decrease in all of the viruses. And then as soon as COVID was back, what you saw again was a resurgence of all these viruses. We then were able to look at, well, what was the next step in the healthcare utilization system from not having viruses and then having that resurgence? And what we immediately saw was the exacerbations in high-risk populations due to asthma or COPD. So during COVID, with all the masking and social distancing, basically the utilization of ED and hospitalizations due to these exacerbations decreased by 60%. And again, though, after COVID, it all came back. So we actually decided that that was a real opportunity to use that tremendous amount of data that was generated to say, we now know if our innate immune activating molecule has the same effect of wearing a mask, we should be able to see a significant impact on the reduction of viruses and therefore exacerbation in asthma. And that's sort of a little bit of the very detailed how we thought about going after our first indication, just as the starting point to ultimately then show transmission prevention. We are very fortunate to have a grant from the Gates Foundation and thank them. And we're very involved with using, helping to develop models, preclinical models to look at transmission prevention and testing our molecule in other models of transmission prevention. But it really has been looking at the data that's being generated, thinking about the direct, thinking about bringing in these interferon stimulating gene biomarkers as part of, along with viral log lowering, and then prevention of the virus due to use of our drug. And I have to say, obviously, I've been out talking a lot about our molecule to many populations and audiences. And when we start by saying, can you imagine having something on your shelf that was safe and effective, that anytime your kid comes home with a virus or your family member comes home with a virus, you can just take this and know that it's going to prevent you from getting the virus? You know, who would be willing to take that? And I do have to say, there is a lot of energy around having something that would help in that prevention of transmission.
Yeah.
So it's just a little bit of the other side of the therapeutic.
I appreciate your perspective from the side of, actually trying to develop a product. And, it's interesting to hear is, themes that we've heard from some of the other speakers, that for these indirect or broader benefits, they're indicators or that you can get of, what may be a benefit there. It sounds like, and you're following Peter, so it sounds like you're still going to have to demonstrate, safe and effective for the person who uses it first. Have you thought about what comes next after approval in terms of trying to get more direct evidence, and how easy does that look from a product developer perspective?
Yeah, so I do think, there is always a lot of post-marketing monitoring of data and capturing of data. But it's a great question, because when we actually started thinking about what do we go into the clinic with, how do we get to transmission prevention, we thought about where do you go and do the testing. And when and the challenge is high-risk populations. Do you look at immune compromise? Can you look in, assisted living facilities, college campuses, things like that? And they can be very challenging to enroll to get that first evidence. And that's why we picked what seemed to us to be such an opportunity to show benefit by reduction of viruses in the asthma and COPD populations to start with. And then from there, I think with that risks, the safety and the risk profile and first labeled approvals, then the kinds of things that we talk about in looking at vaccine populations and households, I think we can then bring it in. The opportunity we have with this activation of the innate immune system is it can really supplement in viral respiratory diseases where there may not be a vaccine to start with. And our goal will actually be to have a seasonal safety package. So you could take it during a 6-month period to show prevention. So that's our ultimate goal. This is where we're starting.
Great. It is a journey. And I do want to turn now, we had a set of discussion questions for this section too. And by the way, we got a lot of great questions from all of you who are joining us in the first session. This is a good time if you've got any further thoughts to send those to us as well. I know we have a couple left over from the previous session that was really about the topic we're covering here, which is better evidence. But in terms of our advanced discussion questions, I'm going to try to combine a few since you've covered some of them already. Maybe we could talk a little bit about what you all see as the systems that are out there now for developing post-market evidence, and how we can build on those to make it easier and simpler as new products come along to extend the kinds of studies that are feasible in the pre-market setting to post-market. Peter, I might start with you. You talked about how doing sort of a direct effect of changes in transmissibility associated with COVID vaccinations over time was prohibitively expensive and not feasible on a sort of like, kind of prospective randomized trial basis. But if you could maybe review for us, I talked about this briefly at the top, the systems that FDA supports now to understand benefits and risks of vaccines, other biologic products, is through BEST and through some other programs. Those got going. At least my brief summary would be they got going to be able to detect and follow up on adverse events that could be significant and could be related to the product, but that needed more systematic population level looks than you could get from just the adverse event reporting system alone, VAERS or the like. But those systems are also now being used to look at effectiveness issues. I think most of this is still focused on the individual direct benefits, but can you say something about how FDA's post-market real-world evidence systems are potentially going to be more useful for assessing indirect benefits?
Yeah, it's a really great question, Mark, and I think this goes to trying to make them even more robust than they are. Right now, Sentinel Best, depending on what time it is, depending on how many contracts we have let, we're dealing with between 60 million and 160 million lives, something in that magnitude. And those are really, if you can get enough coverage, particularly in a given area, right? I mean, even if you can't get all coverage across the country, if you can at least saturate certain areas, both between a combination of what we can get for private insurers as well as public payers, Medicare, Medicaid, you potentially could do the kind of real world evidence studies that you need. Why? Because if you have a catchment area that's large enough and you're capturing all the hospitalizations in a given area, and that's your endpoint, one of the endpoints you're interested in, for instance, it could be hospitalizations because of a respiratory virus, you probably could get some idea of indirect benefit, because you might be able to understand in almost like a wedge design or a case control design, areas where you have high levels of vaccination and areas where you have lower levels of vaccination, and you'll know the vaccination status of those who are hospitalized or not hospitalized. So, I think there's probably ways to get to get there. And again, perfect may be the enemy of good. We may not need to have 340 million people under the system. We may need to just get to some representative places where we get to reasonably good coverage. But we know we know from data that have been done with the CMS database that we can do vaccine effectiveness studies using claims-based data. It's really nice when we get access to the EHR as well. Again, when I say we get access, we don't actually look at the data. Our partner looks at the data, so the confidentiality is maintained. But we know for high-dose influenza vaccine, the effectiveness was documented similar to the effectiveness in a randomized controlled clinical trial through a real-world evidence study using the CMS database, and it was remarkably similar. So I think a lot of confidence that if we have the systems in place, we could potentially get some of these data. And what we will lose in terms of some of the fineness of endpoints like viral loads, et cetera, we may gain in just larger outcomes, which some payers might feel like more confident
They
of,
care
right?
more
If
about
you're,
anyway,
if you're
yeah, from a
costing me
payer
less because you
standpoint.
have fewer people in the hospital, that's probably a good thing, right?
Yeah, we did have one question just to stick with you for one more minute. That came up in the first session. I was holding it for this one around the data quality issues in these real world systems. So, my sense is that they have advantages and disadvantages. Claims, we've seen a lot of news lately about how sometimes the diagnosis information there isn't right, but they're pretty good for things like whether or not a person went to the emergency room with a complication from a respiratory condition or was hospitalized or something like that. On the electronic record side, that potentially would have richer data, as you were noting, Peter, about risk factors of the individual, things that we get at Susan's questions about, if we're targeting a product for certain settings that were higher risk and the like. What's your sense about the state of EHR data quality for the kinds of questions that would be relevant to understanding indirect benefits?
So here, this is a really great question, right? You have to know what questions you're asking for. And you also then, once you do that, you need to spot check. And we do check and essentially audit to make sure we're getting, a sense of reality. Certain things are probably correct when you get them from the EHR. Did you get vaccinated? Did you not? Why? Because you can get the NDC, you can get the codes. You basically can confirm that you've got things right, probably. You can confirm hospitalization dates. You can confirm certain resource utilization. You can confirm whether someone was intubated or not intubated, again, because you've got things like this. And we can check those things. On the other hand, there are certain things that are not fit for purpose currently because doctors just don't record them well in the EHR even. Like, was a vaccine associated with reduction in headache, because certain things are so common and doctors are so bad at recording them, you couldn't, actually rely on what was in the medical record to say that it was or was not present. I mean, that's a bad example maybe, but you get the drift. Things that are not necessarily as cut and dry. Lab values often very good to be able to pull from the EHR, whereas subjective symptoms much more challenging. Not because necessarily of a glitch in the computer system, because of a glitch in us as humans. Either it's not recorded in the EHR, or if it's recorded, there's a lot of variability in how people judge what a severe headache is. So I think this is, it is in general, if you are looking for things that matter, or that will make a difference to payers, I think most of those endpoints are ones that we probably can get a reasonably look at, and we routinely audit to make sure that we're not like missing something as terribly miscategorized in the system.
Yeah. And I do think this issue of how do you create incentives and supports for getting to accurate data in real world context is one we're going to come back to in the next session as well. Natalie, I'd like to bring you back in here both for the general topic of where you see the best opportunities, but I'm also wondering if you might be able to help with one of the questions that came from our attendees related to understanding whether certain kinds of vaccine platforms, meaning the particular technology involved with different applications. I know mRNA has been in the news a lot lately, but there are other platforms as well. And Susan talked about some other ways of treating infectious disease risk that could be applicable across multiple areas. If you could maybe talk a little bit to that question as well, I'd appreciate it.
Yeah, certainly. I mean, when we think about, the search for kind of next generation vaccine or things that are able to offer the additional benefit of reducing infection and thereby provide more indirect benefits. It's an important part of the profile of the product and something you want to be able to capture. And I do think that being able to measure how much the direct benefit in infection probably gets you a good bit of the way. So being able to within the context of a phase 3 trial to be able to capture, for this vaccine as compared to sort of an earlier generation product, how much you're reducing infection, would be a big part of it. I guess the other part is the infectiousness part, and that's where, right, you have to start looking more to biomarkers or other lines of evidence. But if you do have that reduction in infection, that can take you a good bit of the way. Yeah.
Okay. And Susan talked earlier about your post-market work, and in our first session, our panelists speculated a bit on like what magic pill would I like to have to reduce transmission. Are there any magic steps or useful steps that would help you in extending and creating a clear path for demonstrating indirect benefits more easily?
Yeah, that's an interesting one. Thinking about that, part of it still may come to where can we gather the data, right? So if we are effective and our drug prevents transmission and people are out of work less often, kids are out of school less often, how do we measure that? And how do we then assess it's enough of an improvement and say it's due to the fact that there was a reduction in transmission of viral respiratory diseases? So I've been thinking about this, and when we think about FDA and statistically significant differences, is that what we need for having these indirect benefits, or what does it need to look like so people look at those improvements and absolutely know it's worthwhile? And I thought of one example in my local community. A high school said kids can't bring their cell phones to school anymore. And they did that for 6 months, and they said the amount of absenteeism and the grades went up so dramatically that they had to attribute it to the fact that they had stopped allowing kids to bring their cell phones to school. And I thought that is a place where no one doubted the association of the action to the outcome. And I don't have the answer for you, but that's brought me to thinking a little bit of how do we set that bar in these indirect benefits to make it absolute that no one doubts what's been done.
And maybe Natalie, I could go back to you on that question. Where are the best opportunities for extending real world data to answering questions about indirect effects reliably enough to, say, get on an FDA label and communicate confidently to the public about it?
Yeah, I think about the types of studies that you would need, and sort of, the key challenge with electronic health records data is it's all based on individuals, right? But what we need to be able to shift to is something where we can define a unit, a community, a cluster. It's either a household, it's a school, it's a workplace, it's something. But that's the community where indirect benefits are demonstrated. So it kind of relies on data sources where you're able to create a contact structure or able to define some unit that's a step above an individual. And that's when you can start to link people, even if it's just they're at the same school or something. That's where you can start to generate better evidence. But that's going to be a limitation of electronic health records unless you can link families, unless, things like that. And some of the evidence that came out of Israel, for example, that's where they were able to sort of link households. They were able to create households. And that's what you need is you start looking at, okay, well, how many people in the household are vaccinated? Was it the parents protecting the children because the children could not yet get vaccinated? But you need that level.
Yeah, we are, and we're coming to this, I think, in the next panel a bit too, where there have been some steps that CDC has supported, CMS has supported, as more standardized electronic health data become available. CMS has some case reporting requirements now, and the burden of collecting those can be made as low as possible through kind of automated capture from electronic records that doesn't capture everyone in a community, but to to Peter's point, if there's enough participation in a program in a community, a state, or a health system, that may be a pathway forward as well. It does seem like it's easier for countries that have a sort of single health system, or in Israel, there are three, but they do have good longitudinal data. I'm just wondering if any of you all have, maybe Peter, I'll go back to you, since you brought up this point about communities. I mean, it does seem like between CDC and efforts to do better electronically capture data from diagnostic tests that are performed, community-based surveillance resources like wastewater testing and the like, there could be there is maybe a better foundation for doing these kinds of studies at the community level. Are there steps that you think would be effective for on the public side, or maybe especially the private side, working together to create more of a platform like Natalie was talking about?
Yeah, well, I mean, I think there is clearly some role for advanced planning here. And I think this goes to the concept of why it really is worth thinking about. Like, I don't know, we shouldn't like have like magical thinking. The magical thinking that we had our 1 in 100 years pandemic and we're not going to see any infectious diseases for the next 100 years. That's magical thinking. We don't need that. We probably do need to be prepared for the next time we have an infectious outbreak that's pretty widespread. And one of the things that I think you're spot on, we could do is think about how we could construct somewhat, although they're a little bit artificial, we have because we're going to naturally have differences across the country in uptake of vaccines, we may have the ability to look in a randomized manner if we have the right way to measure infectious spread, be it wastewater or other metrics in a given area. That, combined with understanding the vaccine coverage in those areas, could allow us to get at some of these questions in a much more efficient manner, and in a way that's almost incidental to data we're going to obtain anyway, right? So it's not like some big incremental cost. The COVID study that was going to be done was going to involve like going to a college and doing nasal swabs on students like every other day for 3 months, which was going to cost tens of millions of dollars. Here, you would be doing something that would be going on a regular. You'd be doing this as part of your surveillance anyway, potentially, and some of the data would be automatically captured from the vaccines that would be given. So I think you're right. If we did some planning in advance, we probably could bake some of this in. And it's one of those things that you design it, you put it aside, and at some point you activate it when you need to. You probably want to freshen it every few years, but it's a pretty good chance that we're going to need to activate it at some point.
Yeah, certainly important for public health and population health preparedness. And we have a comment from one of our attendees noting that look, in many regions of the country, there either are large single health systems. I just had a chance to catch up recently with Ballad Health. They're in eastern Tennessee, southwestern Virginia, and they're really the only significant hospital system in some of those more rural markets. And they have the capacity to see, at least for the bulk of people in the community, cases that are resulting in hospital visits or health system visits. So I agree with the attendee, and we will pick this question back up with our next panel around the incentives and supports possible as data keeps improving to be able to, either through individual systems or through interoperable data at a community level. A lot of communities in Arkansas, working on it in North Carolina, for making these kind of public health data shared to inform local decisions and to make local communities aware of the risks in their population accurately. It is getting easier, so important opportunities there. We just have a few minutes left in this session, and we want you to cover Any final thoughts, things that I should have asked you about, but I didn't? And then I'd also like to come back to a question that we raised in the previous panel of, doing the studies in well-designed ways, understanding the limitations of the data, but leveraging the increasing quality and availability of data and the methods that can help assure that they're used appropriately, like Natalie, you and others have talked about. Those seem to be getting better. Any points that you'd like to add on how to communicate those results back to the broader public and through their healthcare providers? There are the usual FDA rules for putting information on a label. A claim relates to what the evidence is shown. Just wondering if there's anything you all can add about how to make sure that evidence is conveyed in a way that's as effective as possible for people to use it. I'm not sure who wants to go first on that, or if you have other final thoughts that you'd like to make in our last few minutes, that'd be great too.
And just provide an example from when I was working on a hepatitis C drug with Vertex, back when it used to be that everybody got, providers did not treat people with hepatitis C until very late in the disease because they had to be on a year of interferon ribavirin.
All kinds of side effects.
So when Vertex came up with a 12-week drug, one thing we did was actually go and do a study across how it was being taught at medical schools and treating patients. And it was really interesting, and going back and ensuring you understand sort of the algorithms that doctors are taught when you are then trying to change the paradigm for treatment. So I just wanted to share that example. It worked really well, and then Gilead came in with even better drug, and the treatment of hepatitis C changed dramatically. But I always, it was such a great learning for me that we went in and really looked at and understood how it was being taught to caregivers on treatment.
Thanks, Susan. Natalie, any further thoughts? Or
Yeah. No, this discussion's been interesting. I mean, it's a big thorny problem, particularly like what level of evidence you can reasonably collect and how expensive it is and what we prioritize. And I guess when I think about big thorny problems, I would tend to focus on one narrower part of it. And so, maybe we would think about like a particular vaccine that can be used for caregivers or people who are in contact, right, with immunocompromised individuals, older adults.
they're not that high risk of complications themselves, but they
right,
close contact
but
with
something
people who
where
are.
it really kind of links directly to an actionable policy. You can see that would be a high priority for kind of all for stakeholders. And then it's like, okay, well then what is the level of evidence you need for that in that setting? And I think where you can, when you have such an invested population in that case too, trying to keep those high-risk individuals safe, like then I feel like the communication could flow more naturally.
Thank you. Peter, any final thoughts?
Just want to say thank you. No, I think it's been these are really all interesting things to think about. I do think it is really, we are fast approaching a time when we are going to have to understand individual and societal benefits of vaccination, and they do both. I know we have this incredible bent for the individual right now, but just like we have speed limits to prevent disasters on highways, right? We have mandatory safety belt use to prevent the cost of having people, needing major trauma surgery when they get into massive accidents, to reduce that. Vaccines, I think we have to try to make the case here by a combination of showing how safe we can make them. We have to make them as safe as we possibly can, and trying to figure out ways to help people understand how much they can help those, once again, in their communities. By gathering the evidence to show them what a difference it can make in their communities. So thank you.
Well, it really seems like in this context that we're living in now, as we said, we're not talking about vaccine mandates or anything like that here. Better evidence is really important. We've seen, and we talked about the example of RSV vaccine, where a lot of moms, shown the safety and effectiveness evidence, have used that to prevent serious illnesses in their young infants. And we've talked just now about how to get to better community level evidence systems. Those seem really important, as we've talked about for vaccines, but also for, we talked about in the previous panel, assessing the impact of more use of diagnostic tests effectively, maybe other treatments, and potentially other non-medical steps that people could take, or non-pharmaceutical steps that people could take to reduce infection spread in their communities. And really want to thank all of you for a great discussions on some timely, important topics. Right now, we're going to take a break until 3:30 Eastern time, where we'll come back and talk more about some of the policy implications of the issues that we've talked about today. Thanks again to our excellent panelists for this session, and thanks to all of you who provided some input, questions, comments to help add to the discussion as well. We'll look forward to seeing you again at 3:30 Eastern. All right, I'd like to welcome everyone back for our next session. We're glad you've been with us so far. Now we're going to get some further interesting topics related to policies that can help support regulatory and reimbursement pathways related to understanding and then leveraging the indirect benefits of medical products for infectious diseases. Also a discussion coming with former Commissioner Scott Gottlieb on some of these topics. But right now, I just want to launch into our third session, where we're going to shift to the policy steps that can support development and integration of evidence on indirect benefits into regulatory and reimbursement pathways. This conversation is going to build off our other recently released report on integrating indirect health benefits into biomedical policy and the implications for federal agencies. Our team for this paper reviewed the authority and past actions by the FDA, some of which we've talked about already today, by the Centers for Medicare and Medicaid Services, and to some extent other federal agencies that are involved with issues like data exchange and the CDC on supporting better community health information, actionable information. We put these together to identify a set of regulatory and reimbursement reforms that could increase awareness of and the impact of products that can have these indirect benefits. Among the key themes for this paper was an assessment of how FDA could build on some of the examples that we've talked about already to develop more systematic ways of considering community health benefits alongside individual benefit risk. We described in the paper some examples of how FDA has applied community risk standards for approving products, like, for example, certain kinds of fentanyl products, and for considering regulation of nicotine related products, alternatives to combustible cigarettes, and youth use and things like that. So there is a foundation to build on there, where clearer FDA guidance building off these examples might provide a better pathway forward. Also, steps that FDA could take, like we talked about in the last session, to provide clarity and maybe encourage the development and use of platforms that could assess community level benefits or indirect benefits around individuals, using the improving availability of real world data and real world evidence systems. We also talked about, in the paper, reviewed some of the steps that CMS has taken that are very relevant to indirect benefits from infectious disease products, and how to build on those. those. For example, some coverage decisions and decisions about copays, such as for diagnostic tests in the COVID context, where the indirect benefits to people besides the Medicare beneficiaries who are using the product were clearly important, ways to make that more systematic. CMS also provides and uses quality metrics and incentives and payment reforms to support better outcomes for individuals and the populations they serve more broadly. Not everyone is in CMS programs by any means, but Medicare and Medicaid beneficiaries are among those who are often at highest risk from community spread of an infectious disease. So some incentives related to improving reducing the community level risk of infectious diseases, which could be done through the kinds of products that we've talked about here today, could be relevant as well. CMS also has data collection requirements. These are often viewed by providers as potentially burdensome, but for understanding the extent of infections in a community, CMS has taken steps under the leadership of one of our panelists in this next session to collect data routinely on cases resulting in hospital visits for viral respiratory infections, which when done efficiently using electronic health record, electronic data feed, something that the Centers for Disease Control has also tried to advance, electronic case reporting for reportable conditions, reportable infectious diseases, can provide more timely and complete information on what's going on in the community. That's good for both community awareness about the risks that individuals in the community are facing, which might affect their behavior and their choices about medical products in itself. But also, if the data are complete enough, as we talked about in the last session, potentially a way of learning more about whether vaccines or use of certain kinds of treatments or diagnostic testing coverage and strategies have an impact on important infectious disease burden outcomes. So these are some examples of the kinds of policy reforms that we discuss in the paper, and I got really looking forward to hearing from our panel about all of this. We go to the next slide. Very pleased to be joined by Haider Andazola, who's a counsel at Manat, Phelps and Phillips, where he specializes in healthcare payment and some other CMS related issues. Lee Fleischer, who's the founding principal and CEO at Rubrum Advising and is the former director of the CMS Center for Clinical Standards and Quality that worked on a number of these issues related to reducing infectious disease burden that's so important for the Medicare and Medicaid populations, but ties into community level impacts of infectious diseases that we've talked about today. And then Joe Franklin, who is special counsel at Covington and Burling and former policy director for FDA's principal deputy commissioner, where he worked on a wide range of issues related to better data and evidence to inform regulatory policy, among other topics. So Haider, Lee, Joe, thanks for being with us. Maybe we could start with each of you, some opening comments on this topic of how to advance policies to support understanding and then leveraging indirect benefits of medical products for infectious diseases, or anything else that you'd like to react to that you've heard in our discussion so far. So Haider, let me start with you. And Haider, you're on mute.
Sorry about that. Can you hear me okay?
Yes, that's great.
All right. Good afternoon, everyone. So I think when I was asked to speak at this panel, the way that I historically have approached any kind of coverage or payment issues for medical technologies is really looking at Medicare access through a four-legged stool, which I think is helpful when we think about whether medical products or other types of payment incentives that are intended to promote access to I guess, transmission reducing therapies or preventative medicines, et cetera. The way that I look at it is first, typically we got to start with the benefit category. And I think there are plenty of benefit categories in this context to consider. And again, a benefit category, because Medicare is a defined benefit program, you need to be able to find something in the statute that allows Medicare to cover the technology in question. And so, you have benefit categories like incident to drugs that are administered by a physician. You have specified covered outpatient drugs that are specific to the hospital outpatient department. You have DME drugs, Part D drugs. These are all sort of drugs. But then you have other benefit categories that might be helpful in thinking about this transmission reducing impact that we're trying to promote. And that's things like supplemental benefits under the Medicare Advantage program, which is a growing program, or now represents the majority of Medicare beneficiaries. Physician services or physician supplies, right? So things that physicians provide to patients, which they buy and then bill the Medicare program for. Those are more indirect ways to maybe influence and promote innovation for these types of technologies that have an impact on reducing transmission rates, but they're still potentially relevant and helpful. And then, there are more emerging benefit categories. They've always been, not always, but they've been in the Medicare statute for decades now. But it's not until recently where you started to see CMS start to wade into how to interpret those benefit categories. And I think a prime example is the additional preventative health services benefit category that has been in the statute for some time now, since the ACA, but it's only recently that CMS has evaluated that benefit category in the context of a drug product, specifically the PrEP medications for HIV. And that, I think, is just an example where there's a lot in the statute, and I think there might be some flexibility to interpret different benefit categories in a way that might help improve access. And then, you start thinking about coverage, right? So the other leg of the stool, I typically think of coverage as the reasonable and necessary standard under Medicare, which I think the white paper that Duke put out emphasizes that historically it's been interpreted as individual benefit. What is the benefit to the patient receiving the therapy? But, there might be, when I look at it, I think there's some flexibility to interpret the statute more broadly than that. And we can talk about some of the mechanisms that CMS might have to be able to do that. And then the third leg is the payment, right? So this is where I think probably most innovation can happen here in terms of the incentives that CMS is able to establish. And in some cases, you might be limited by the benefit category, right? So going back to the first leg of the stool. So for example, drugs, it's pretty clear that if they're administered in the physician office, they have to be ASP plus 6% or at least paid under that methodology. But what if they're administered in the hospital outpatient department? You might have a bit more flexibility there because they're technically specified covered outpatient drugs and the statute doesn't prescribe a methodology. And then what if you're dealing with a payment incentives, right? So Mark mentioned quality reporting programs. That's not a benefit category in so much as it is a mechanism, a payment mechanism for hospitals. So you might be able to explore how to craft quality measures that incentivize transmission monitoring and reduction, or the use of transmission reducing technologies, which, Medicare Advantage, for example, has a star rating that is associated with how many biosimilars do you use. And so there are different payment mechanisms that CMS might be able to leverage that are not really tied to a benefit category and don't come with that limitation. But of course, they're much broader potential impact. So you have to maybe get in a bit more stakeholder buy-in. And then also the last leg of the stool, which I think might be less relevant here, is just coding, right? What is the mechanism, whether it's a payment or a coverage issue, to drive the kind of change that we're looking to have, whether it's a HCPCS code, whether it's a quality measure, which can take many years to actually create and validate and implement into the system. All of these things, I think these four-legged stools are sort of addressed by the recommendations that Duke has made in the recent publication, and some are more targeted. So for example, the NCD maybe more of a coverage issue, but some are more cross-cutting that can span across all of the legs of the stool. And I'm really looking forward to this conversation and seeing, maybe drilling down on some of them and how they might be implemented in practical aspects.
Great. Thanks, Hyder. Really appreciate that framing. Conference CMS related, I could call it perspective. Lee, we'll go to you next. Oh, mute too.
Yeah, thanks. Okay, thanks so much, Mark, and to the entire Duke-Margolis team for, the outstanding brief and the opportunity to speak today. As you did at the beginning, just disclosure, Rubrum Advising is a market access life sciences firm, including diagnostics. And Hader so nicely laid it out, but I want to talk about those flexibilities that we got to use during COVID-19 and MPOX, which I think is the other opportunity we had to look at benefit. And, while there are a certain amount of flexibilities, the CARES Act gave an unbelievable amount of flexibility that wasn't there, or I don't think CMS could use. But a couple interesting things as far as public health and the idea of isolation, which became so important prior to the development of the vaccines and many of the therapies. And I still remember when the administrator at the time, Seema Verma, talked about the value of paying differently for diagnostics that could obtain an outcome in 48 hours versus 5 to 7 days. That it really wasn't valuable to be able to know 5 days hence that the nursing home resident or the individual should isolate and therefore protect the rest of the public. So I think that was
and there was a payment incentive related to that that followed.
Right, that's it. They paid more for quicker. So I think that was great. In that same way, the over-the-counter, CMS really did extend its authorities by looking at over-the-counter testing. And my colleague, Mina Seshmani, working hard to figure out and working with the general counsel to pay for over-the-counter tests, which, in a positive way, we didn't know what was happening as well. Or in a positive way, people could test at home. In a negative way, we lost some of the information we had by not doing external testing to understand what was happening from a public health perspective because of the reporting mechanisms. The third being the four-legged stool that Hyder talked about in vaccination. And you've talked a little bit about this. I was involved with the hospital, the healthcare worker mandate. And it was interesting. It made it through the Supreme Court because that was really the safety of those who were in the hospital. And if you read through, and we used a lot of the CDC research to say that the ability to use that lever of the conditions of participation was really that we were protecting those we served, and that was part of the safety code for hospital and Medicare certified facilities. So, really we could use public health, and at least in a 5-4 decision that was affirmed. MPOX presented a more difficult circumstance because we didn't have, at the time I was there, we didn't have those authorities. And I remember the daily questions of what can CMS, Medicare, but what got even more complicated, Medicaid. And Mark, we can talk about the patchwork of what states would or would not pay for became really important. As Hader mentioned, we really still interpret, at least during my tenure, R&N, reasonable and necessary, really is about the individual with some extensions. So the idea of paying for a diagnosis as opposed to surveillance is really the question. Without a U.S. Preventative Services Task Force A or B recommendation, how does CMS have the authority without a statutory change to pay for diagnostics for older adults? And where we sort of landed was we could pay for if somebody had a suspicious infection, and we could sort of surround the ring of people that they were exposed to because of the high risk that they could come down with an infection, but we couldn't just go out and pay for, CMS could not pay for everyone. So I think, as Mark, as we talk about in the paper, it nicely outlines, I think that compromise and keeping the statutory authorities that CMS has without being challenged of paying for the ring, which I would call public health, not just the individual. Same thing for the vaccine, whether it's under EUA, and Joe might be able to speak more about what does approval, that is actually an approval, but what if it's not an EUA and it's pre-approval? When can we use those vaccines? So I think those are the key points. I'll just end with, it's a really interesting thing about the data collection, Mark, that you mentioned and we've talked about this at Duke-Margolis numerous times. What's the burden? What's the value that you have to get back to the hospitals? And, that was their question all the time. What is the right level of information that really is more than just we want it, but we'll use it to protect the public health, and we'll provide it back to those who are actually providing it in the first place, i.e. the hospitals. So I'll stop there, but hopefully gave some examples of what happened during those 3 years.
Well, also a lot to follow up on there too. Thanks, Lee. Next, I'll go to Joe.
Thanks, Mark. As Mark mentioned, I'm counsel in the food, drug, and device practice here at Covington and Burlington, DC. I just want to note that I'm not appearing on behalf of any entity today, and really appreciative of the Duke team for putting together the background research on this and their lengthy project on this topic and today's discussion. So today we're discussing the development of, I kind of want to ground us here in the FDA part of the discussion after Hader and Lee have done a nice job summarizing the CMS points. So, I feel like it's important to note that we're discussing the development of evidence, of a product's indirect benefit and the use of that evidence to inform regulatory decisions, especially in this panel. And I'll focus on regulatory decisions by FDA. Lee mentioned EUAs. I'm primarily going to focus on non-emergency, kind of FDA's normal course review of products. So, I think I wanted to emphasize that if it weren't for the opportunity to generate robust evidence on indirect effects, we wouldn't be talking about this downstream question of regulatory decisions that would be informed by that evidence. But I think it's important to focus on these regulatory decisions from a kind of nuts and bolts policy and legal perspective. I'm going to focus on drugs and biologics related decisions at FDA, but I'll note that similar principles apply to diagnostics and other types of device decisions. So I think at a high level, I think that there could, consistent with what the Duke team has recommended in the white paper, I think that there could be real value to having FDA apply its expertise and its process to evaluating indirect benefit when a manufacturer decides to seek an indirect benefit claim in the labeling for a vaccine or therapeutic. I think we can talk about the value of FDA involvement more, but I think you can summarize it by saying that FDA's expertise in evaluating complex evidence to support claims could be a really important step in clearly establishing indirect benefit for a product. I think we could explore that a bit more in the panel. So let me provide a quick summary on FDA's kind of approval standard, which I know we're all familiar with, and also the benefit risk framework. So for drugs and biological products, which includes vaccines, FDA reviews marketing applications in which the manufacturer or sponsor, in FDA parlance, proposes indications and information to be included in the labeling. Indications including claims on how the product may be used. So for a drug to be approved for marketing in the US, FDA must determine that the drug is safe and effective for use under the conditions prescribed, recommended, or suggested in the labeling. So the focus is on the labeling, on the claims that the manufacturer proposes to include in the labeling, and whether the evidence supports a finding of safety and effectiveness. FDA's long emphasized that because all products can have adverse effects, the demonstration of safety requires a showing that the benefits of the drug outweigh its risk. And this is where the benefit risk framework comes from. And FDA has provided quite a bit of guidance on this. As Dr. Marks emphasized, for vaccines in particular, FDA's approach ensures a high degree of safety. But the benefit risk framework is how FDA has structured the process of evaluating benefits and risks. FDA has emphasized, and I think this is alluded to in the Duke paper, that in circumstances, FDA's benefit risk assessment, and FDA has emphasized this in guidance. So there's a 2023 guidance on the benefit risk assessment, kind of FDA's most up-to-date statement on a non-product specific level on this policy. And it emphasizes that the benefit risk assessment incorporates broader public health considerations for both the intended patient population and others. And FDA has noted that in the communicable disease context, risks related to disease transmission are important considerations. I mean, so there's a couple of examples in that guidance, but I think that this points to one of the areas that there could be some policy progress. So let me describe the kind of three areas that I see where stakeholders could explore more in the FDA context. These overlap with the Duke white paper recommendations. Really commend the team for developing that work. But let me kind of expand on a few of these. So number one, as I mentioned, there could be real benefits to having FDA applied expertise for evaluating indirect benefit, but it needs to be, I think it needs to be clear to sponsors and to the public how FDA is going to consider indirect benefit claims, or how it would consider indirect benefit claims and for FDA to describe that in guidance. And sorry, for FDA to describe in guidance how the agency would consider the claims in the context of the risk benefit framework or otherwise. And we can talk a bit more about what that means. And I think that's because there are a couple of examples of products that we've talked about in this conversation. There's a couple of previous products where FDA has considered benefits that might be other than the individual that's being treated. But I think that there could be a lot more clarity on this topic. And I think I do want to emphasize that it's important and really critical that the decision to seek indirect benefit claims is optional for sponsors to avoid unnecessary delay and kind of provide optionality to the sponsor, because it can be, as Dr. Marks and others emphasized, expensive to demonstrate adequately indirect benefit. So number two, I think it's almost always important for FDA to apply its expertise to another type of guidance development, not just how indirect benefit would be considered in the context of the benefit risk framework, but really clear guidance on specific outcome measures, validating the ability to extrapolate from outcome measures that might be included in a clinical trial to a demonstration of indirect benefit, study designs, and most critically, I think, the use of real-world data. I think our previous panels have focused on opportunities to use real-world data to support FDA decision-making on indirect benefit potentially, but I think that there's a lot of details that could be refined, and it would be a great opportunity for FDA to provide some thought leadership and expertise on RWD evaluation along the lines of what Dr. Marks was mentioning. And third, and I'll finish here, if indirect benefit is primarily measured, I think there's a question about process. Is indirect benefit a question that is primarily coming up, at least when it comes to FDA decision-making in the post-market context, or is it something that would primarily be developed as an add-on to pre-market trials, for instance, or both, right? And I think that this is kind of something, this gets to the development of evidence and the incorporation of indirect benefit into FDA's framework. And I think it's also worth exploring whether there are other types of process mechanisms that would be important in the indirect benefit context, like an accelerated approval type paradigm, where you might be able to establish some upfront evidence for indirect benefit claim and then confirm that with post-market studies. So I'll turn it back to you, Mark, but those are my quick observations about FDA.
Very, very helpful. So we covered CMS, now FDA. I do want to turn to evidence. I was interesting idea at the end about sort of accelerated approval equivalent here. As Peter was very clear, the products aren't going to get improved unless the direct benefits are clearly demonstrated, but it does seem like from the discussion today, surrogate at the time of approval for indirect benefits would be a good area for development too. And we did have a set of discussion questions that I'd like to cover in our remaining half hour plus together. It's been a great discussion so far, laying out frameworks and connecting to the previous sessions and these feasible policy steps. But those discussions questions started out with questions related to advancing the generation of evidence, which each of you touched on to some extent, especially Lee, in talking about some of the things that CMS has done around encouraging development of data that can be very helpful for healthcare providers and understanding community health risk, and Joe, what you were just describing as well. I wonder if we could start by asking any of you, and Joe, maybe I'll start with you on the FDA side, and then we'll progress to the market side. A great summarization of what FDA could potentially put on the label, and how that potentially can drive or clarify what evidence is needed. You didn't mention another part of your job was to help FDA try to develop better platforms for real world evidence and the like to actually generate this sort of stuff. So I wonder if you could say a little bit more about things that you think FDA could do along with providing this clarity of evidence to encourage more use of either real world evidence systems or otherwise to help fill out the indirect benefit evidence and understanding on the labels and in the public.
Yeah, great question, Mark. And maybe I'll connect this to the first discussion question, which is what claims could be included on the labeling related to disease transmission reduction, or risk transmission reduction risk, or risk reduction, or other types of indirect benefit claims. And I think that I wanted to emphasize there that is the question: is what should the claim, what claims would a manufacturer seek, and what claims would FDA review support? And I think that it is a that can be a evolving process as the manufacturer looks to the available data sources. So it's connected to the question about what data sources and what evidence generation methods there are out there. I mean, I think the previous panel I thought was fascinating, thinking through different types of measures, including I think at least two categories of measures. One would be measures that are derived from transmission risk that could be measured potentially in a study, in a trial type setting. I think that was alluded to in the previous panel. And then a very different category of measures that look at population health type of metrics that may be collected from very different data sources, real world data sources or other types of data sources on the population level. And I think that when it comes to what FDA can do to advance the use of these data sources, I think it's a critical question. I think number one is FDA clearly needs, that this work involves resources, and I think that FDA needs the expertise resources and resources to pursue the type of evidence platform development projects it's pursued in the past. One of those Dr. Marks mentioned is the BEST and related Sentinel efforts. And I think that there is an interesting question about the types of information that a manufacturer could rely on from BEST to support some of the indirect benefit claims. If that information is primarily coming from payment claims data, then I think there are certain types of outcomes that might be supported if BEST were to incorporate other data sources. They might lend itself to other types of claims that could be explored. And then I think that it's likely that manufacturers who are trying to support indirect claims are going to look beyond just the data sources that FDA has access to and look to other types of real world data sources if they're relying on data from outside of a trial. And that's why it's important for FDA to I guess I'll come back to what's important for FDA to emphasize from a policy perspective. I think that there's really a complex set of considerations when it comes to FDA's ability to evaluate data quality and provenance and overall reliability for data sources, not to mention the information value that can come out of them. So I think that I don't want to kind of come back to the point of FDA issuing additional guidance on this topic, but I think that the information coming from FDA on what its expectations are is critical in the evidence space.
Yeah, and FDA has taken a lot of steps over the last couple of years to develop further guidance, I should say, on real world evidence in general, and to have teams that can potentially interact with product developers around their specific application. I hope all that work continues. I don't know that much of it has really been focused on these indirect benefits too, and maybe something we can help move forward is some leading cases, whether it's for vaccines, diagnostics, therapeutics, what might be some good lead cases for that further development to help flesh out the further guidance that we talk about in the paper. Really helpful comments. Thanks, Joe. Lee, let's switch over to the CMS world. You talked some towards the end of your opening comments about what CMS does and how it's evolved in terms of data requirements related to kind of community public health threats. I think most of our audience probably knows that there are a lot of, this has interactions with the public health side too, where there are a lot of reportable conditions that healthcare organizations are supposed to report for CDC, public health purposes to understand about disease spread or understand about antimicrobial resistance or things like that clearly have implications for others. I know you spent some time on trying to modernize, improve, get that system functioning more effectively and automatically across agencies. And you could say a little bit more about that. I know we're not talking about, specific payments for specific treatments here, but more, conditions, expectations, features of being in the Medicare program and getting paid, which, you don't want those to be too burdensome on providers. And ideally, as you said, would be data that an organization like CMS working with data standards groups, the Assistant Secretary for Technology Policy, CDC, and their efforts to get more automated, less burdensome, more timely data shared on the public health side together. It does seem like a lot of relevant data for better understanding indirect benefits in the Medicare and Medicaid populations.
Yeah, thank you, Mark. And we did spend a lot of time, and Duke-Margolis was involved in a lot of these discussions, and you personally. And it really came down to a couple things. One is you've got the Medicare and Medicaid certified facilities, and therefore those regulated by the conditions of participation. But then there's all the physician offices and other facilities where you don't collect it. And for the hospitals, which were part of the HITECH Act, in which they actually got money to create EHRs, that was easier, I would argue, and I had argued to me, like the nursing home arena, which is incredibly important for the spread of infectious disease, as we saw during the pandemic. They don't have robust reporting systems. A lot of them were still using Excel spreadsheets and faxing them in. And that is not productive, a productive use of time, particularly during the pandemic, when taking people away from frontline care, to do that. So there was a lot of balancing of what was right. And I still remember the times that we started to discuss as they went from a very large data set to what is that parsimonious data set in which you can actually act on it. And the hospitals would frequently ask, how can you get sort of heat maps back to them of knowing what's happening in the entire community? Because they had to report both to local and state and then potentially federal. So we did spend a lot of time thinking through, could USCDI, could the laboratories, and I still remember in your conference room having a discussion of laboratories, how, getting things directly from the laboratory machines back to public health would be the ideal scenario. I think there's still opportunities in that space. A lot of times people have said, well, if you take, Epic and Oracle, you've got, at least in the hospital side, 80%. Is that good enough to do public health, and could it be reported through, TEFCA or some other mechanism directly rather than from the hospitals themselves? So I think those are all opportunities. We just need to do it better, whether it's USCDI or in some aspects quality measures, which are mandatory to report. But the problem with quality measures is we would know once a year, maybe quarterly, and it usually was delayed. So I think that automatic is really the goal that would make everyone feel better, and providing back to the providers useful information, not just federally, I think is key.
Yeah, and it does seem like there is incremental progress in that direction. You mentioned, some of the major electronic health record vendors are at least turning on, APIs or the like that could help with public health reporting. We have some interoperability now in North Carolina. Other states do as well to get more direct reporting. The key is making it as least burdensome as possible. And I think something like some of the major labs are now, for some lab results, are participating in CDC surveillance systems that are more automated. So it seems like a promising direction, even if we're not there yet. So we've talked some about improving the data capabilities to support indirect benefits through policy steps. Maybe you could turn back to payment, and I'll come back again to the FDA side too, Joe, don't worry. But payment steps related to indirect benefits. Hyder, I really appreciated your four-legged stool characterization. You talked about some of these opportunities already. Quality measures, alternative payment systems. Any that you'd particularly like to highlight that seem most promising from a sort of a statutory authority standpoint, and maybe align with some of the current administration priorities around improving population health, intercepting health risks, including infectious disease risks early? Any that you'd like to come back to and talk about a little bit more?
Thanks, Mark. Yeah, I mean, before I go to sort of the payment mechanisms, I do want to reinforce, I think, what Joe was describing in sort of the critical nature of getting the FDA to weigh in on what this indirect benefit looks like. Because when you're talking about drug coverage under Medicare and the application of the reasonable and necessary standard, it's basically done to label. You don't really see the either CMS or the MACs condition coverage of a drug that is inconsistent with the FDA approved label, or more narrower than the FDA label. There might be, quantity limits or something that's sort of indirect, but it's still ultimately tied to what the label says. And so what the label says is really critical in how the MACs are going to apply coverage. And we can talk about reasonable and necessary standard as CMS might interpret the term in a national coverage determination, but NCDs are such a fractional piece of how much coverage decisions are actually made in the Medicare program, that really the focus is how are the MACs making these coverage determinations, whether it's on a local coverage determination basis or on a case-by-case basis, and how can you influence that? And it seems like obviously CMS providing guidance to the MACs on how they might consider this indirect benefit, but also what the FDA label says, I think will make the MACs a lot more comfortable in maybe thinking more expansively about what reasonable and necessary means in the context of transmission reduction. But to your specific question about what payment mechanisms there might be currently that might lend themselves to this, I mean, I think there's honestly quite a bit. The challenge is that it's a little patchwork because, again, you're dealing with a regulatory system that tends to be siloed, right? And so, you have the NTAP, new technology add-on payment, which I think is an obvious mechanism to maybe enhance payment for some of these products. And it kind of reminds me a lot of what happened with the antimicrobial products several years ago, which again, the issue is transmission reduction, right? And CMS improved the NTAP, both the marginal payment and the sort of the application process for certain types of antimicrobials that were substantially innovative, right? Qualified infectious disease products or ALPADs, forget what the acronym for that one is. But it's sort of the same idea here. You could imagine CMS improving NTAP payment for a class of transmission reducing products, however I might define it, through the NTAP. Or you could also look again at the drug payment add-on, right? Maybe CMS establishes a separate process that allows for the creation of a additional add-on percentage for certain products that are able to demonstrate transmission reducing capabilities. And and CMS has authority to do that because they have very broad authority to develop payments both in the outpatient department. So I described specified covered outpatient drugs, and they just have extensive equitable adjustment authority. And they sort of did this with the NCTAP, if you recall, during the pandemic, where they adopted mechanism for certain COVID therapies to essentially give them an NTAP-like payment that was separate from the NTAP, and it was sort of an in between, but it represented a additional payment incentive for providers to use this technology. And then you have, conditions of participation, you have quality reporting programs. I think frankly, probably the most impactful mechanism or maybe strategy for addressing transmission reduction priorities is probably CMMI, whether that's through a model that focuses on transmission reduction and creates an entire payment system from scratch to try to improve, whether it's population-based, product-specific based, outcomes-based, whatever. I think CMMI's waiver authority is just so expansive that they could really do a lot of work here if there was the policy will to do it. And then I wonder if, Medicare negotiation program might present another opportunity as we have, as sort of more and more products are negotiated. Vaccines, they're not exempt from Medicare negotiation. They get certain ceiling price, but they're not ultimately exempt. So, once you start trickling down over many years to the products, to additional products that are not sort of blockbuster drugs, but still have significant expenditures for the Medicare program, I think CMS might be able to evaluate these therapies in a way that considers transmission reduction as a factor. So that might be another mechanism, but I think it's much more narrow and limited. But I think if you sort of ask me what's the best way to do this now within existing mechanisms, I would probably say look at quality measures, look at how you might be able to improve access to or improve payment for specific drugs, or think creatively for like clinical diagnostic tests, for example, that are over the counter, maybe treating them as physician supplies and creating G codes to reimburse physicians for the cost of them acquiring these products and giving them to patients. And then CMMI. I think CMMI probably has the most ability to really test a lot of different mechanisms out and track data and create an environment for tracking, reporting, surveillance in a way that is difficult right now with the patchwork of regulatory silos that the Medicare that represents the Medicare program.
Great, thanks, Howard. That's a pretty long list. Thank you very much. Before we go back to FDA, maybe Leah could go to you. Anything else you'd like to add from a CMS standpoint? I know you did some work while you were there in trying to better coordinate CMS and FDA activities, something that Hyder also emphasized, the evidence that comes from with approval on a product is important, maybe not completely dispositive, but it's certainly very important for CMS coverage and other policy decisions, and that kind of coordination, as we're seeing in just yesterday, another national coverage decision announced. I think you were involved in at least some phases of that, where the early interaction between product developers and FDA and CMS was, really helpful to get to, I think what's being regarded as a smooth result there.
Yeah, and I have to call out to your previous panel member, Peter Marks, because we would talk constantly, so we would know what was coming up and what was coming out, so that the minute FDA made a decision, we could actually implement that. And Joe knows that too, that coordination really was quite helpful with regard to being prepared to have the agency pay for it. And during MPOX, Hillary Marston, another person at the FDA, constantly talking about what we will see and how do we actually create that payment. Hader mentioned a really interesting authorities, which is CMMI. One of the questions being they just canceled, we don't know what will happen, but they said they're going to sundown like the Maryland state models. But in a state model, they can take the perspective of what is the evidence and should they pay for things from a public health perspective, because the benefit would be in a total cost of care, something, Mark, you've been talking about for years. Mm-hmm. But I think what you're really suggesting, and it's interesting, CMS and FDA has a memorandum of understanding. Most people, when I came in, there were a lot of questions about that, but they're allowed to share. But the way they share is actually from the companies coming in and asking to talk to both, which is, I think, where we've gotten TSET to. So that, and in some ways, IDE studies, category B, where the outcomes of interest that CMS can comment and say, this would meet RNN and safe and effective. So I think, having more, and particularly as people develop the vaccines and the diagnostics and understanding at the end how they could meet both, is a goal, I think, of everyone in both agencies.
Right. Thanks. And you're right about the evolving innovation center pilots, and Hyder mentioned the flexibility there. I know there's a strong emphasis with the new administration on getting to cost savings, and I think there's more coming soon on how to do that. As you may remember, in the first Trump administration, there were efforts around moving further away from fee-for-service to direct contracting, and maybe even at a geographic level. So I don't think we're done with these regional or state level initiatives. In fact, a number of states, North Carolina, Arkansas, et cetera, have some ideas that they think could really help get to better population health by moving further, faster, and these seem like, to the discussion so far, good ideas to incorporate in that around ways to reduce population health risk. Let's go back to Joe. We've had a good discussion so far. I know you've been involved in a lot of these issues, both in your time in government and since. Anything you'd like to add in terms of how to accelerate the process of developing and using evidence on indirect benefits in FDA and other policies?
Yeah, I guess I would maybe focus on two areas. One is the policy area and one is technical. On the policy side, I would just reiterate that I think that there are some real important clarifications, whether it's in the context of the benefit risk framework at FDA or kind of in a different context. I think FDA, it's hard to push the conversation around potential indirect claims around for disease transmission risk reduction without a clear understanding, I think, about how FDA would evaluate those claims kind of from a policy perspective. regardless of what the evidence source is. Switching over to the technical side, I think we talked about a range of technical of data sources that would support indirect claims, from measures that might be collected during a trial to measures that might be collected about specific outcomes for specific patients in the real world setting, and then population health measures. And I think that because of I think that the abundance of potential measures, there's a lot of important work to do to identify how specific study designs and data sources can be connected to specific types of claims. So
Yeah.
I think that there's an intriguing value for FDA to be lending its expertise to this area of evaluating indirect claims.
Yeah, and a lot more real world data and methods to work with there as well. I know we're almost out of time, and I try to get we've covered a lot. I think a lot of the stuff that was in the chat from the questions from our attendees related to policy. One that I wanted to follow up on was, you all noted that some of these steps, especially on the payment side, but also on maybe the regulatory side and sort of evaluating evidence on indirect benefits, is different in a public health emergency. And it's understandably so, because the risks of infectious disease spread by definition are much higher. But as you all know, as we've talked about already today, we're seeing infectious disease outbreaks around the country, increases in measles cases that we haven't seen in years, even deaths. It's been a particularly challenging flu season on top of the other respiratory viruses. And as we talked about as well, there's a potential for further threats always out there. Are there steps that can be taken along the lines that we've learned about in public health emergencies, maybe outside of actual public health emergencies, to strengthen the infrastructure, to clarify the pathways for developing and having products available that not only benefit individuals in terms of vaccines, treatments, diagnostics, but also the people around them more? Anything that could make this more built into ongoing policy, where we're seeing continued infectious disease threats, serious adverse outcomes, and deaths.
I would maybe try to look to the Medicare Advantage program as a potential sort of, given that it now represents 50% of Medicare beneficiaries. I feel like they, as a sort of private administrator of Medicare benefits, have a bit more flexibility to offer especially supplemental benefits. And I think there's a lot of inertia right now when it comes to supplemental benefits. You have your popular ones, vision, dental, fitness in some cases. You're starting to see a more diverse array of supplemental benefits. And I think CMS could try to do something, whether it's with the bidding or something technical, to encourage MA plans to maybe offer supplemental benefits that are associated with transmission reduction, whether it's buy over-the-counter tests, or go see doctors more regular for screening than what Medicare would ordinarily provide, et cetera. I think MA plans could pose a promising, under existing authority, a promising avenue to maybe explore some of these policies.
Thanks, Hyder. Lee?
Well, I agree. I'm not always sure Medicare Advantage follows, and therefore many people believe we need national coverage decisions to ensure sort of uniform. I actually, a couple areas, but as Hyder said, in the annual wellness visit, which is only used by a very small percentage of Medicare fee-for-service beneficiaries, do we add something there about some sort of screening or take advantage? But the other question really is, right now, the way the structure of screening as opposed to diagnosis really requires the U.S. Preventative Task Force. And we've seen a lot of questions about ARC, even today, about whether there'll be funding. Do we need to think about, is there a faster, more mobile authority that could say this reaches A or B level evidence, and this gets to Joe and the FDA determining evidence, such that CMS could pay for screening. Because I think that would really help in a public health emergency.
Well, certainly there are opportunities to generate the evidence faster than there used to be. Joe, I'll give you the last word on this or any other topic you'd like to bring up.
Well, yeah, this is a great topic. I'll just say really quickly that I think trying to extrapolate from the experience of the public health emergency, obviously, I think, under extreme pressure, FDA and other, agencies learned I learned a lot about application and review of kind of a totality of the evidence approach using different types of study designs to inform decisions. And I think also learned how hard that process is. A lot of the transmission risk reduction research that we've been talking about today is conducted in the public health setting. And I think that it's an important question to ask about how you bridge the gap from the types of work that has been conducted in the public, in the literature, to what FDA would be looking at to support a claim. And I think that's fertile ground for kind of understanding what, what data sources, what study designs, and kind of what overall principles FDA will apply to make sure that its decisions are as robust as everyone expects them to be.
Great. Well, thanks to all of you for a thoughtful discussion, both of the overall policy frameworks used by FDA and CMS especially, but also how other public health agencies fit into all of this, and some provocative ideas building on the discussion we've had all day about what could happen next in order to increase the evidence and get more benefits for populations from the choices that people make and the products that they have available to benefit themselves in the context of infectious disease burden. So thank you all for being with us. And now that brings us to our last, not panel, I guess we call it virtual fireside chat. I'm very pleased to welcome Scott Gottlieb, Senior Fellow at the American Enterprise Institute, and involved in a lot of other things as well. He was the 23rd Commissioner of the Food and Drug Administration until 2019, so there for an important period in the FDA, and that was after several previous roles at FDA going back to 2002, I think, when he was about 12. Now at AEI, he's continuing to do a lot of work related to drug innovation and medical product innovation more generally, but also public health and a lot of work on infectious disease. Many of you may know him from his extensive efforts around not just COVID, but other infectious disease threats that have arisen since then. And Scott, we've already talked today about mpox, about measles threats, and about other resurging infectious diseases, as well as potential emerging ones, and trying to combine that with, on the one hand, technologies that are good, not only for protecting individuals, but potentially for reducing spread, vaccines that can help, therapeutics that can help, diagnostics that can help, better ways of and better opportunities to develop evidence on these products and to support their development and use, but also some challenges with, despite this progress and resurgence in infectious diseases happening. And I've been talking a lot recently about some of these current infectious disease threats. I'm wondering if we could maybe start with one that's been in the news a lot lately, the recent measles outbreak, where we've gotten some more evidence that I don't think we really needed, that there are indirect population effects when the use of vaccines fall. With measles, you have to get to a pretty high level, very high level of vaccine use to get to herd immunity. But I really appreciate your thoughts on where things stand now, this overall context into which these opportunities and challenges for reducing the burden of infectious disease can best address these recent trends.
Yeah, when I was 12 and I first joined FDA, I was fortunate that the standards were a little bit lower, and the commissioner at that time was a little bit more
I
accommodating
know,
to
let
youth.
anybody
So,
in, right?
so yeah, everyone could get a job back then. Um, Look, what's happening in West Texas and other parts of the Southwest is deeply concerning. I think that just to level set, we probably have a lot more cases than what's being officially reported. Certainly, you get that impression when you talk to officials who are on the ground and some people at CDC. And if you just sort of extrapolate from the fact that we have 2 deaths in the setting of this outbreak right now and some very sick people who are hospitalized, if you believe the case fatality rate, which I think most people do, is about 1 in 1,000. Certainly, you would impute from 2 deaths that there are more than 300 cases and maybe upwards of thousands of cases. And one of the fatalities was a person who was in the home who never presented at all. And I think that gives some indication of the fact that people are getting sick and not presenting. So this outbreak could get larger before it gets smaller. Um, the concerning thing is that we look at the overall vaccination rates in the US right now, hovering slightly above 90% for MMR, which is well below herd immunity. But that masks the fact that you don't have uniform coverage across the country. And so states where the vaccination rates are in the high 80s and some states are in the low 80s, there's pockets in those states where the vaccination rate is significantly below that. And we're looking at state-based averages and national averages. But when the infection gets into these pockets of significant under-vaccination, there's probably communities that are in the 70s. If you're looking at a state that's in the 80% range or 85% range, that's sufficiently low that when the vaccine gets into that community, it's going to spread pretty quickly. And I think that this is, getting to the point of some of the discussion earlier. I think that this is sort of a secular trend now that's going to be hard to reverse, and certainly the continued dialogue around vaccines generally is to discourage parents from getting the kids vaccinated. The recent comments about cod liver oil and vitamin A and steroids being perhaps therapeutically useful in the setting of measles, which just isn't the case, uh, further reinforces for some parents who might be considering getting their kids vaccinated that, well, perhaps is a therapeutic, and they may, tip that sort of equation in favor of not getting their kid vaccinated, thinking that there's a therapeutic available in the same way that some people may forego flu vaccination or COVID vaccination, recognizing that Tamiflu is available and Paxlovid is available. And I'll mention I'm on the board of Pfizer. There you can argue that's not a completely irrational decision for someone who's otherwise at low risk for going vaccination on a premise that there's an active therapeutic available. It's not something that I would counsel, but it's a decision that some people will choose to make. And in that case, there is a therapeutic available that could help rescue people who become infected and become ill. But for this disease, there is no therapeutic available. And so I think that you're going to continue to see downward pressure on vaccination rates. And this is not something that's going to be easily reversed. I think that the ability to influence people's decisions and educate them about the pros and cons of vaccination is going to have to happen at a community level. I don't think the national dialogue is going to change. And I also don't know that's the most effective place to be having these conversations. I think there's a lot more that state-based and local-based health authorities could be doing to help address some of this vaccine hesitancy that we're seeing and are doing. But I think that's where the action is going to be, and that's where the most effective action can be.
And the emphasis on community level fits a lot with what we've talked about today, where there, for example, is good evidence that vaccination use can reduce spread in people that come into contact, people in the community. You mentioned that measles, we don't have great early diagnostics when people are transmitting a lot before they're really symptomatic. We don't have great treatments. In other infectious diseases, we do. For all of this, though, what are the best ways to engage communities? Because that's kind of what's needed to partner with the range of technologies that are available, whether it's vaccines, therapeutics, diagnostics, and ones that I think you'd see more development and uptake for if there was clearer evidence about impacts at the community level. You've been involved in a number of efforts to improve the data on surveillance. We wrote a paper together about things that CDC and CMS might do to make better data on infectious disease threats available locally. What kind of evidence could better engage and better support those local community-based efforts?
Well, I think certainly educating people about their individual risk continues to be important. And it's not just people who are unvaccinated, but even people who, you know, might choose to get vaccinated but not complete the series, or get one child vaccinated, not another. And a lot of these children who are most vulnerable and getting infected are in households where you have young parents, you have moms who are pregnant. Congenital measles is devastating. You have
Yeah.
other kids in the home who might not be able to get vaccinated at all and would be very vulnerable, newborns, young babies. And we saw the recent case where a woman who had measles went into a maternity ward to deliver, and now all those newborns in that setting were exposed to measles and they're excessively vulnerable. So I think, educating people about that individual risk. But I also think at a community level, it's easier to have the discussion about the collective risk. At a national level, the idea of collective, the collective good of vaccination feels kind of remote.
Mhm.
But when you're at a community level and you're, going to school with your neighbors and, seeing other children in a class who might be more vulnerable than others to measles, or young moms who have infants who want to protect their children, but then some parents are choosing not to protect their children, and they may be importing the vaccine into that environment where, maybe a young mom's pregnant, maybe a young mom has a newborn at home who can't get vaccinated, and now that child who chose not, the parents who chose not to vaccinate their child are putting at risk that family. I think that appeal to sort of collective action to help your neighbors and help protect your community is much more resonant if you're advancing those arguments at the level of the community. And that's why I think sort of community-based efforts to try to promote vaccination are far more effective than national efforts, because at a national level it feels kind of remote, and people might be more likely to adopt the view, well, I'm not getting my kids vaccinated, but everyone else is getting their kids vaccinated, so I'm not going to be putting at risk everyone else's kids. That's not the case. And I think trying to bring home that argument and pull it through is important. It's important to do it with data, and I think it's much more effective at a community level, where you can actually model out what the risk is going to be to how many, young families there are with kids just who, even if they choose to get vaccinated, aren't at an age where they can get vaccinated, or maybe are at a point where they got one dose but haven't gotten two. And we've seen 4 kids in the setting of this measles outbreak who were vaccinated, who got measles, and they were likely kids who got one dose of the vaccine. So, these kinds of realities at a community level, I think, are much more resonant to people who, I think will be swayed by the argument that you need to take collective action to protect people that you go to school with and you shop with and you live next door to. And that's why I think the arguments much going to be effective at that, are going to be much more effective at that level.
What are the best ways you think, to empower those kinds of effective community-based efforts to share information, pull together? We've seen examples around the country, a lot of them, of leaders of healthcare organizations or business leaders who have spoken up about the available evidence. We've worked with, or you've worked with, people like Caitlin Rivers, who are trying to develop better data systems that can be used locally, kind of the weather report related to infectious disease risk in a community. What do you think would be, kind of connecting, especially better data, to these efforts? What are the best ways to support them?
Yeah, well, it's the qualitative arguments that we've sort of outlined here, but it's also, getting to your point, the quantitative arguments. And I think trying to look at data at a community level, and trying to model what the impact could be to a community when you fall below a certain vaccination rate, and there are people who come down with measles in the community, and what the risk is to the community. We don't have really good data sets, or they haven't been extrapolated or extracted from in a way where you can make an argument about the risk of spread within this particular community. And even stepping back from West Texas, where I think the risk is now apparent, just looking at other communities where vaccination rate levels maybe 80%, I think it still feels remote. People don't understand what it means for a community to get to a vaccination rate of 80%, and what is the risk to young children and toddlers in that community who either can't get vaccinated or only have one dose of the vaccine and want to be protected, maybe have to be protected because they're even more vulnerable than the average child. And in what it would mean if someone who's chose to be unvaccinated imported the virus into that setting, into a school setting where, the vaccination rates might be 80, 85%. it doesn't feel like that one child who makes the one introduction can put the entire community at risk, but in fact that's the case. And I think we haven't really modeled that well and explained that risk well. And I think if we did that, it would be much more tangible for individuals who are making that
Yeah.
decision to forego vaccination. So, I would try to take the national level data that we have and the state-based data we have and really extrapolate it to what it means in a community setting when you fall below a vaccination rate, overall vaccination rate of 85%, what it means to the community, how many newborns are in that setting, how many pregnant moms are in that setting who now could be put at excessive risk because of the decisions that other people made. And I think again, at a community-based level, people people do things to protect their community, right? So, it feels much more direct, and no one wants to be that outlier family that were the ones who introduced that risk to others. So those are the kinds of arguments I would be making. I think to the extent that we could support it with data and what the transmission dynamics would be like in that setting, the more convincing it's going to be. So I would be trying to go into those communities with low vaccination rates.
Local
Look at a
data
state.
and
Yeah, look at a state that's at 85% and then pull out from that what are the communities that are far below that are at excessive risk, and try to go into those communities and educate people around what that risk means.
To complement that, is there any point in getting more evidence on vaccine and other medical products safety, effectiveness for both individuals and for people around them? We talked earlier with Peter Marks, who described the FDA's best system for tracking vaccine use and associated adverse events, and also health benefits for individuals and even people around them. How we're getting to the point where, for many communities, we've got pretty good data from lab reports and health systems on uptake of vaccines, also testing, other steps that show how well a community is responding locally. Do those additional data sources also help, or do we just need to keep it simple at this point?
Oh, look, I think those data sources help. I think if I was in a policymaking seat now trying to influence this debate, what I would be looking to do would be to take some of the data collection schemes that we currently have, find ways to augment them, because you can always do things to improve data collection, and then kind of relaunch it, rebrand them, because there is this sense, and I don't think we're going to fully sort of refute this notion that we don't do enough to collect vaccine safety information. There's this whole trove of safety information that's been kept from public view. All these kind of inaccurate perceptions, and you continue to see sort of rhetoric and dialogue that reinforces this view. And as much as you want to push back against that and sort of re-educate people and say, no, look, we've been collecting all this data all along. It's available. It's transparent. I don't think you're ever going to fully win that fight. And so what I would be doing if I was running FDA now, or running a public health agency, is finding ways to kind of relaunch what you do. And it's not just a rebranding campaign. I think in the context of it, but it's partly a rebranding campaign. But I think in the context of a rebranding campaign, you can look at ways to try to expand the footprint of what we're doing to collect information, make it available to consumers, find more seamless ways to make it available, more interactive ways to make it available, more ways to interrogate it at a community-based level. So local reporters can also extract the information and write local stories based on the local risk. But it also is a rebranding exercise, and there's some virtue in that. I think both you and I have been engaged in those kinds of exercises in the past as a way to kind of reinstill public confidence in what public health agencies were doing. And there's nothing wrong with that, especially if it's done in the context of actually trying to improve the data collection, the data delivery. And I think, the data delivery, particularly at community level, could be really, really impactful, because then it creates a much more realistic perception among consumers that the information truly is available. Because when they're looking at national averages and state level data, it doesn't feel like it's real information in a way. But if they're looking at information that talks about their specific community, and we had this for COVID, right? So we know we can do this. We created heat maps, and you had data right down to local hospital admissions and local transmission dynamics. And so we know we can do this. We just haven't done it for things like measles. And this would be I think measles in particular would be a good place to start if we were going to try to do this around some of the routine pediatric immunizations.
Well, and it doesn't have to be just about measles or just about what's in the headlines, but as we were talking about in the last session, these risks of infectious diseases are ongoing. The data capabilities are getting better, and it sure seems like a worthwhile step at this point to try to strengthen their connection to local communities. We have assuming the Senate gets busy next week, perhaps a new FDA commissioner very soon who could take some of this on. Any other advice for him along these lines?
And partnering with local health plans, partnering with local and state officials, partnering with local health plans and local healthcare providers and institutions. I think they would be really interested in getting engaged more in data collection and trying to promulgate some of this information back to their local communities. If I was sitting there, I would be looking at a couple of communities that you can extract to try to test some different kinds of approaches. Pilot project, 10 or 15 communities, make it small enough so you're not boiling the ocean, and try to develop some of these local models for data collection and data distribution. Again, partnering with some of the local healthcare entities. I think that there would be a lot of uptake for that among the healthcare providers in communities. And you can, in the context of doing that, pilot some models that you could then try to encapsulate in more of a federal effort.
And learn more about what does make a difference, and maybe even some other steps beyond vaccines.
Right, and it's easier to do measurement at that
help.
level too, so you can see what influence you're having on consumer perceptions.
Yeah, and help maintain. We talked about this a lot today too. Getting past and recognizing some of the limitations of data, addressing them, and getting to, again, good evidence-based local policy. I want to end up on one final. It's been a great discussion about just how important communication is and just how important local, reliable, timely data is to support that, and a lot of potential now more than ever. We are seeing the downward trends, though, in vaccinations. There are, as you know, a lot of products in development that potentially could do a better job, not only in reducing the serious infections in individuals who use a product, but maybe in reducing transmission. We had some discussions earlier around vaccines with different modes of administration or products that might activate other aspects of the immune system. There certainly have been, in the case of COVID, diagnostic tests that can be talked about those too, for other conditions made more easily available at a lower cost. How do you see other technologies like next generation vaccines and diagnostics, therapeutics, maybe helping to offset some of the decline that we're seeing with vaccines alone?
I think that we've seen over the last 25 years a real resurgence in vaccine technology and investment in new vaccines. And I kind of date this back to the early 2000s when you were at FDA and we saw new vaccine approvals like Gardasil, and suddenly this became a segment that was profitable to invest in again. We've seen blockbuster vaccines come onto the market, and so now there's a realization within the pharmaceutical industry that vaccines can be a profitable business and you can develop new IP. Because after all, a lot of these pediatric vaccines, DTaP, polio, MMR, are really commoditized. Prices have been driven down very low. They're not great businesses. They're not high margin businesses, but I think we've seen high margin products come into the market, and they'll eventually go generic and be available at lower prices too. And these prices get negotiated down because there's bulk purchasing and Medicaid programs and things like that. And so I think you're seeing a resurgence in investment. I'm worried that some of the kind of anti-vaccine sentiment is going to make people concerned about continuing to invest in these things, and some of that could pull back. There's only a small subset of companies that have fully invested in this space, and some startups, but it's very expensive to bring a vaccine through development in the context of a startup, and it's hard to fund in a venture capital syndicate. So this is sort of a fragile market. The prospects are probably better for vaccines targeted to older populations, which value absolute efficacy, and I think have more awareness of the risks of infectious disease than younger populations, and that's where I think a lot of the development is going to be. But I think that this is to your point, to your fundamental point, I think this is a real opportunity, and we've seen a lot of innovation. I think that there's a real risk that you could see some pullback from those investments if this current trend around vaccines generally continues. And we'll see what happens to vaccination rates. I think the biggest risk right now that I see is that there could be a move to try to move things that are currently on the recommended schedule on the CDC's overall schedule away from recommended vaccines into the category that Gardasil sits in, where it's sort of joint decision making, where the recommendation is that the decision to take the vaccine should be a joint decision between the parents and the physician, which sounds very logical and appropriate. Everything should be a joint decision between the parents and the physician. But if you move vaccines into that schedule, and that's the schedule where Gardasil sits, it's more of an optional schedule versus the recommended vaccines, which end up being part of the school entrance requirements and are more of a mandate. And those are vaccines like
Not, and maybe
polio and
not
DTaP and
reimbursement
MMR.
for that. It's
Right,
state, not,
exactly.
primary care capacity.
Right.
Which,
And so I think that if I'm worried about what the next policy step by HHS could be, I worry that they're going to look to do that, because it would align very cleanly with some of the rhetoric from and a dialogue from Secretary Kennedy, where he says, "Well, I don't want to take away your vaccines. I just want it to be a decision between physicians and parents." And well, that would mean moving all these vaccines into that other category. And so if I was looking into a crystal ball about what the next kind of policy step could be along the lines of what we've seen recently, that would be my concern, that there would be a move to do that. And I think that if you think about decline in vaccination rates, my going in assessment would be this is going to be a slow erosion. But if things were to be moved off that recommended schedule, that could create a real inflection point where you see a real downward step in vaccination rates, because I think it would put pressure on a lot of state legislators to weaken the standards, weaken the requirements around school entrance requirements and school mandates. And that would really have a significant impact on things like MMR and DTaP and polio. And those are the ones I worry about the most, because those are the ones that are most dependent on sort of community level vaccination and the collective action that we talk about when we talk about herd immunity.
Well, important point to end on. This is a very important time from the standpoint of population health and infectious disease risks, and tying back to a couple of other topics we talked about today. On the healthcare payment side, the administration has expressed a lot of interest in moving towards stronger primary care, stronger population health that in principle could use the data we've just talked about, could reinforce and provide a better capacity to engage the public than really stretched primary care providers have now. And then on the FDA side, a lot of opportunities to clarify and improve use of data, even locally. But that too is going to depend on, and a lot of ways to engage product developers who may be feeling a little uncertain right now, even though the technology opportunities seem better than ever. But you're going to need a strong FDA staff that can engage effectively on this under strong leadership at the agency. So
yeah, and FDA has been very, I think, adept at taking existing systems, reinvigorating them, modernizing them, and sort of relaunching them and rebranding them in ways that they resonate more with consumers. And that's what I'd be looking to do here with some of the data collection schemes that we have in place, make them more robust and refashion them to kind of conform with what people's expectations are right now.
All right, really important times. Thanks for being here, Scott. I know it's been a long day for you for this very timely and relevant discussion to infectious disease burden and hopefully a healthy future.
Thanks for taking a chance on me when I was 12, Mark. I'm grateful for the opportunity you gave me.
Great. Well, somehow I think this is not the last time we'll be hearing from you. So thanks for joining us, and I'd like to also give a special thanks now. We are about out of time to all of our participants, all of our attendees who had some great suggestions and questions along the way. Sorry I didn't get to quite all of them, but we very much tried to bring out both the challenges in this space and the very important new opportunities to make more progress, even in the face of some falling confidence in vaccines and an emphasis on individual choice, hopefully well-informed individual choice, as we highlighted. Just to wrap up, I want to give a special thanks not just to our panelists who had a lot of insights on a range of challenging issues today, but also to the team at Duke-Margolis that put this effort together, bringing together a range of perspectives, trying to keep it current in a complex area of population health and policy. Brian Cantor, Sabine Sussman, Nancy Allen LaPointe, Maddie Cordell, Molly Shields, Luke DeRocher, Hannah Vitiello, and Marianne Hamilton Lopez. It's a very much a collaborative effort across different parts of Duke-Margolis. Finally, thanks to all of you who attended. This is a really important area of public policy and public health, healthcare reform. We'll be sticking with it and look forward to staying in touch with you all. As I mentioned before, materials from this event are available online already. The video from this event will be posted soon on our website and our YouTube channel. In the meantime, I hope you all enjoy the rest of the day. Thanks again for joining us, and we hope to see you again soon.